Abhishek, are we good to go live?
Yes, ma'am. Just in a 1 minute.
Hi, Varsha.
हाय.
मी ना ह्याच्यावर आहे त्यामुळे मला सगळेजण दिसत नाहीये. दिव्या
हो, सगळेजण दिसत नाही.
But
स्क्रीनवर
you know,
फोनवर ना फोनवर सगळेजण एका स्क्रीनवर येत नाहीत ना. हाय प्रिया.
yes.
Hello, madam.
परदेशी सर.
Are we good to go?
Yes.
Good afternoon. Bye, sir. Good afternoon.
Good afternoon.
Good afternoon.
Good afternoon, sir.
Good afternoon, sir.
Charu ma'am,
Good
should we
afternoon,
begin?
sir.
Yes, please begin.
Good afternoon, all. I welcome you all on behalf of Study on Female Breast Committee FOXY and AMOX Public Awareness Committee for the COR Connect live webinar, a webinar on breast health issues, the Pink Saga. I I invite you all to join the lightning the lamp and inaugurate this webinar.
I think we will hand over the proceedings to Dr. Priya. Dr.
Yes,
Priya, can we hold on with the prayer for a minute while Dr. Priya speaks?
yes.
This is very funny.
Am I audible?
Yes, Dr. Priya.
Yes.
Yeah. A very warm and lovely afternoon. I would like to welcome all our guests, our delegates, and the faculty, our President, Sir Dr. Rishikesh Pai. And we are indeed blessed to have the gracious presence of Dr. Sunita Tandulwarkar, Dr. Pardesi Sir, and Dr. Sneha Bhuiar Madam. So we are really blessed to have you all in this lovely webinar. The webinar, which is COR Connect, the Pink Saga, and it is related to the breast, on the breast-related health issues. This is hosted by the FOXY committee, or the Breast Committee of FOXY, and the Public Awareness Committee of the AMOX. And Dr. Charulata Bapai, Dr. Priyankur Roy, and Dr. Monica Umardan, they have been extremely instrumental in this wonderful webinar. I would like to request him to put the CV of Dr. Charulata Bapai.
Thank you, Dr. Priya. Thank you for that introduction. And indeed, a very good afternoon to each and every one of you. December is a fantastic month of joy, festivities, and enjoyment, vacation. But while everybody vacations and enjoys, we doctors still continue our medical educational activity for the betterment of our patients. And it is this same thought and idea with which we have come forth with the Pink Saga, which is a webinar on breast health issues conducted along with the AMOG's Public Awareness Committee. So sincere thanks to Dr. Priyankur and Dr. Monica for joining hands with the Breast Committee for this fantastic webinar. And we have the august presence of none other than Dr. Rishikesh Pai, sir, the chief guest of today's webinar. We know he is so busy. He's traveling all across the length and the breadth of the country along the river Ganges. And we can see that he's connecting to this webinar through, on his way for the next stop of his yatra, joining India. It is indeed a big Badlav moment that we are seeing, and he continues to inspire us with his energy and his new thoughts. Welcome, Dr. Rishikesh Pai. And of course, hi, sir. Our guests of honor for today are none other than our very able, very likable, very approachable Dr. R.P. Pardeshi sir, who is the president of AMOGS. And welcome, Pardeshi sir, for our webinar. Our next guest of honor is none other than Dr. Sunita Tandulwarkar, who is our dynamic, inspiration. She combines energy, passion, technology, and of course, leadership qualities and leads by example. So welcome, Dr. Surita. And of course, none other than Dr. Sneha Bhuiar, who is my mentor, friend, philosopher, and guide, chairperson of the Breast Committee 2019 to 2021, who has nurtured Breast Committee with so much love and passion and taken it to such amazing heights today. So we are indeed honored to have all of you here as our, privileged guests. Of course, our esteemed faculty and our dear delegates joined for this webinar. We invite you all for the inauguration of this webinar. Mr. Abhishek, can we please have the prayer?
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय ॐ शान्ति शान्ति शान्ति.
With that, we request the good Lord to take us from darkness to light and enlighten us on so many issues which we need to know, which we need to go ahead with. Thank you so much for the prayer. Mr. Abhishek, do you have Dr. Pai's CV and the video? Mr. Abhishek?
Charu, video chi jarut, CV chi jarut nahi ka?
I know. So I just want to just say that, sir, you inspire us with your energy, with your new thoughts, with your Badlav movement, and your CV is known to all. You are so dynamic. You have been the president of so many organizations. You've received so many awards. You've chaptered so many books. You've been the pioneer as far as infertility is concerned, and you continue to guide us. Over to you, sir, for your words of wisdom.
Chalo, you are all there. So I must, I would like to show you one sec. I would like to, how do you, Niranjan, do this? Okay, this is our Dhanbad. The first time I'm coming to Dhanbad. It's a real, well, I should be ashamed of myself that I'm visiting the city after we have become president. But the problem is that we have got 263 societies and it is an amazing country, As I travel the breadth of this country, you realize how large and vast the country is. And, it's very exciting to, come to each of the, like yesterday I was there in Ranchi, I never expected it's such a beautiful city and the people there. And it's really fun, I really enjoying this, connect with the people of our, and we are 38,000. They're all very committed. It's a fantastic feeling, I feel that we should, all the presidents will have to do it after me now, I think. They'll have to connect with everyone. I sent Dr. Pardesi, I said, when you become president, you'll have to do it. So anyway, so I would like to say that I would like to, Dr. Pardesi, our AMOX president is there, and our dynamic Sunita, who is already been the IIG president, vice president of Foxy, and ISAR, now she'll become president of ISAR as well. So great technically sound person. Technology is very important for all of us. Then of course Charu and Sneha, the torch bearers of the Breast Committee, and then our new incoming vice president also is there, Girja Wagh, who will be the next year's. She'll be blazing around the country next year. And a lot of other people are also, I can see many people, Komal Chavan, our dynamic, committee chairman now, just left the committee, medical disorder committee chairman, and so many other people. Chavan, my friend, there, Varsha Lade, our, she's going to do the next AMOX, and Dr. Singhal is there, Dr. Garud is there, and I can see Priya Vora. So there are a lot of people, and one Breast Committee is one committee which I was, when they started this committee, I was wondering, kya karenge ye log? Malum nahi, whether they'll do a great job. But see, the leadership is what makes a difference. If the leaders are so good, the committee becomes very strong. So that's very important to, the leadership really is very important in anything you do. The CEO is very important. And if the CEO is strong, then everything clicks. So I'm very happy and I'm very excited. I'm just now entering a new phase of my life by coming into Dhanbad, and just we are launching your committee workshop. So, I wish you the very best from the coal city. Me and Niranjan were saying that tomorrow early morning we'll get up and go into the coal mines and see what happens there. So we are very excited. And tomorrow from here we go to Jamshedpur, another very city I never visited in my life. The steel capital of our country. And then from there, the last phase will start, which is the Durgapur and Burdwan and Calcutta. The one city which I'm missing out in these 21 cities that I have visited in the last 35 days is Durgapur. So that's the really, eating my head. Ki how, how can I reach Durgapur? How can I not miss it? It's in my mind. So anyway, it's very exciting. And I was yesterday telling everyone that we have, the IMA president was there, or Ranchi. I told them that we are more powerful than even the IMA, and which is a fact. The federation is at present very powerful association of very committed individuals, and it's growing very fast. And one of the important things we must do, I was just thinking during this last 20 days, is that we must build a membership also. Na? We have to cross the American college membership is around 50,000. We must cross them. So this year we will cross the American. Lot of our members are not members, and Dr. Pardesi and seniors are there. Dr. Sunita, Dr. Girija. We have to find out a way where we can have a membership of the Foxy directly. So we make the breakup of the membership into two parts. One is the local society membership, and one is a transferable Foxy membership directly. Because what is happening because of this issue of membership, a lot of people are not becoming, continuing themselves as members. So before I leave, I want you to show the love and affection. See this. They all come to. They have all come here. This
Wow.
Apurva is there.
Apurva.
And they are all there here. That's Priya here. Manoj. Tarini is there. So yeah,
Wow.
this is Dhanbad. This is Dhanbad.
Priya and Tarini. Yes.
Awesome.
We just landed, and so you go get on with your academics
Wow.
and let us get on with our connect. Bye bye.
Thank you so much. And we've gotten the blessings and love of so many
Bye.
other people along with you, sir. Thank you
Okay.
for being here. Thank you for joining. And we welcome
Okay.
Yashodhara Pradeep, Madam, our Vice President in charge of the Breast Committee. Madam, thank you so much for joining and for, showering your blessings through your presence. And of course, Girija, our own POGS member, our CP-elect President Foxy, welcome to the webinar. Thank you for joining us. And now I hand over the mic to Dr. Monica Umbargan to kindly introduce Dr. Pardeshi sir and seek his blessings. Dr. Monica.
A very good afternoon to one and all. Thank you, Charu ma'am, for introducing my committee also. First and foremost, I would like to thank you to associate with Amongst Public Awareness Committee as well as the Foxy Public Awareness Committee, because I represent both Foxy as well as Amongst in the Public Awareness Committee as well zone coordinator. I have the pride and privilege to introduce Dr. Rajendra Singh Pardesi sir, who is at the helm of Amongst.
Monica,
Yes.
it's okay. Let us skip that.
Yes, sir.
Good
Sir,
afternoon,
whatever-
everybody. Respected Chief Guest, Dr. Rushikesh Pai, sir. Dr. Rushikesh Pai is doing really excellent work, and basically basic work, but important, connecting the people. If we will connect people, we can go together and we can succeed if we will go together. So, sir, our sincere wishes to you in your future endeavor in Foxy and all your activities. So, respected Dr. Sunita Tandwalkar, Dr. Sneha Boyar, Dr. Madhuri Patel, Dr. Alka Pandey, Dr. Yashodhara Pradeep, and my amongst office bearers, Dr. Sujata Dalvi, Dr. Monica, Dr. Komal, Dr. Rashmika, Dr. Varsha Lahade, and Dr. Charulata, and incoming President Dr. Girjawad and Dr. Charmila. First, I wish to congratulate Dr. Charulata Bapai Chairperson of Foxy Breast Committee, and Dr. Monica Oberdan for organizing such an academic feast on breast health issues. Charulata Bapa is successor of Dr. Sneha Boyar. Sneha Boyar has done a lot of work in breast committee. I think up till now, she's means taken this committee on the height. With the galaxy of speakers like Dr. Divya Singhal, Dr. Girija Wagh, Dr. Snell Jamal, Dr. Charulata Bapai, Dr. Rashmi Kahar, and all chairpersons and panelists, I think this is going to be a great event. I wish every success to Dr. Sunita Tandolkar for her future endeavor in Foxy as Foxy President, Dr. Sneha Bhuyar and Dr. Komal Chavan for their future endeavor as Vice President Foxy. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you so
Thank
much,
you
sir.
so much.
So much, sir.
For
So
the
it
word
is
of
like, your parent organization, and I couldn't think of a better place to start off my webinar than my parent organization, who has supported me so much throughout my entire, endeavor to become the chairperson. So, Dr. Pardeshi, I would like to really put here on fact that thank you so much for all the love, encouragement, and support that I received from you and the entire team amongst, and helped me fulfill my dream. Thank you, sir. Thank you for blessing our webinar. Thank you. And
Thank you so much. Ma'am, you can please introduce the guest of honor also.
yes, please. So our next guest of honor is none other than our dear Dr. Sunita Tandurwadkar, madam, who's been the past president POGS, who's been the past president of IAGE. She has been the senior vice president in ISAR, and so many other titles. We've seen her actively in Foxy for I don't know how many years, and we really wonder how she can, manage so many things at one time. Her academics, her advances in technology, her continued medical education, her newer papers and presentations, and her further personal and professional goals. Dr. Sunita, we warmly welcome you for our webinar. We wish you all the best for all your future endeavors. You are contesting for the post of President Foxy, and we really support you for that throughout. And over to you to bless our webinar.
Thank you so much, Charu. Thank you. Am I audible?
Yes, you are.
First of all, Charu, let me hugely congratulate for becoming the chairperson of a breast committee. I have seen you working for it along with Sneha Bhuyar, who has done amazing job. As Rishikesh says, even I used to think कि breast committee में करते क्या है यार, इतना breast लेके वो कैसे पूरे year they will do the program. And Sneha has done amazing job. She made you work with her as a national convener, and I think this coordination, this continuation by the same leader. So what happens, the work done by previous chairperson probably gets continued, and then the new chairperson add on new horizon to that committee. And just congratulating, I know when you were contesting how much you were working hard for it, your passion was palpable, and you made us all proud, Charu. Charu is working in POGS for years together. The most important character of Charu, apart from her intelligence, apart from her hard work, apart from creativity, what is needed most is dependability. Any work you give, maybe a small CME or maybe a very big breastcon conference, which she did successfully in 2022, shows her leadership quality. And I know by entering into the Foxy Infertility Committee, slowly you will join to the vice president and the president post. Your leadership quality will evolve. And probably because of your leadership quality, you will achieve higher and higher posts. That's what my wish is. Today is your first webinar, and I'm so glad that you invited Dr. Rishikesh Pai. Again, his leadership quality is, we all in India, in 1 month, what he had done, which people could not achieve in entire year, if I would have been a past, I said, oh my God, this is impossible. Myself, Nandita and Reshma Pai, we keep on talking what he has done in 1 month. I was a vice president with Reshma Pai. We had done huge work. I'm not saying that. But this was unbelievable yatra which he is doing. 3 things he is combining: public forum, so awareness. Then he's doing a health education, free camps. So again, he's helping in all society. And third, he's making a CME, because I attended with him in the first session. And this gynecological CME helping the gynecologist. So it is very difficult to dream. That is what the leader can take the organization to a higher level. And what shows commitment is his committee chairperson. For a president, this is a really need a passion to come and preside and give you blessings for your first webinar. Shows how much he loves each and every committee member. Dr. Pardeshi sir, you made AMOGs, you have taken from Nandita, and we all used to think Nandita was such a big leader and how you will take it, and you showed your leadership quality, you showed your inclusiveness. You took each and every society member into AMOGs, and you made Maharashtra the most vibrant society. I congratulate you, and I'm also thankful to you for making me a state coordinator so I can learn a lot more from you. Dr. Yashodhara, I saw, though for the first time I'm joined from the mobile, I can't see everyone, but your Vice President, Dr. Yashodhara, I saw her, and I'm so happy that she's supporting her committee chairperson so beautifully. Your another idea of getting PAC committee with you, with Priyankur and Maharashtra Society, where Monica, the vibrant chairperson of a PAC committee at national level, at the state level, she's accompanying you. You are taking Dr. Priya Vora and Pratibha Baldava. Why this is important? Why I'm observing this? Because these are the young people, and you are taking them and making them understand how the organization works, how to talk with, how to compile the scientific program, how to conduct the CMEs, because everyone cannot start with the national or international programs. They have to start with small. And this is how you have to take the people. And of course, your scientific program, I always see whenever it is a breast committee, even with Sneha, I used to see the topic of mastalgia, abnormal nipple discharge, the breast screening camps, how one should organize with the Dr. Divya, Girija, and Snehal. I think you've chosen the fantastic speaker. I'm sure. Girija, you are always a fantastic speaker, and I would love to be there. Above all, your panel, where lump and bumps in breast. I really love the word you created, the bumps in breast, along with Rashmi Kahar, very dynamic from Amravati that way. This is what Pardeshi sir has done. He has chosen these diamonds and given them the complete shape and given them the platform to perform. You have taken the best of the panelists. Varsha Lahade, very dear friend, Nasik Society President, Dr. Manisha Ghate doing huge work in Chandrapur, along with her Chandrapur friend, Dr. Priya Shinde, and then Dr. Garad, Dr. Seema Patil, Dr. Vandana, my very, very, very dear friend from, and my houseman from VMMC, and Dr. Rajendra Chavan. I don't know why anyone will not join to this webinar. I wish you all the best, Charu, and I look forward for your dynamic career. And I hope so I get an opportunity to be with you in your 3rd year of committee. Thank you.
Thank you. My God, Dr. Sunita, that was such an exhausting, outstanding input that you gave to all of us. And indeed, along with so many other things, we have to learn how you respect each and every individual around, and you praise the smallest of smallest thing in the person opposite you. Thank you so much, Dr. Sunita, for joining us. May all your wishes and dreams come true, and we are with you. Thank you. And now it is my privilege to introduce none other than my dear Dr. Sneha Bhuyar. I think it is time, it has become that my name will follow Sneha Bhuyar's name. And I like it so much, essentially because I have been following her right since our BJMC days and our Sassoon General Hospital days, where she has been my chief resident and I have been a junior resident. And not only did she teach me OBGYN, but she also sheltered me in her room, because we all know that the condition of living for junior residents is quite pathetic. But I got a posh and separate room along with Dr. Sneha. And, that was the time when I realized that she values friendship so much. And the minute she decides, she will hold your hand and take you forward. And that is exactly what she did to me. And I cannot thank her enough for her entire guidance that she gave me as I rose to the post of chairperson after her. And I'm sure that with her skills, academic skills, her leadership skills, her kindness, her positivity, her very clean and simple demeanor, her command over the language, her command over each and every topic, we have seen that she has been talking on so many issues and topics all over the country. She's going to be one of the best leaders that we can have. And so, Sneha, best wishes for your future endeavors as you stand for the post of VP Foxy in the coming elections. She's a governing council member, ICOG.
Thank you, Charu.
Chairperson of Mental Disorders. And I think that we would really like to hear from you. I don't know how it feels to be past chairperson. And over to you, Sneha.
A very good evening to all of you. Thank you, Charu, for that kind and I would say a very generous introduction. A very good evening, respected Dr. Rishikesh Pai, the President Foxy, a very vibrant, dynamic, innovative, and a visionary, very inspiring president, I would say. The Vice President, Dr. Alka Pandey, and Madam Yashodhara Pradeep. Today's chief guest and my mentor, Dr. Pardesi Sir, AMOX President, very calm, composed, and inclusive, easily approachable person. Of course, Dr. Sunita Tandulwadkar, a very inspiring leader, the brain and beauty, the very updated academically and technologically as well. Very good evening to Dr. Girija Wagh, my dear friend, and Dr. Komal Chauhan, the MOCs, Dr. Priya and Pratibha, and of course, Varsha Lahade, Taru, Divya, I think all my dear friends, a warm welcome to all of you. Though I have just finished my tenure as chairperson, I still welcome you all to this committee program. And Charu, a very hearty congratulations and all the best to you for your tenure. Dr. Monica, hearty congratulations for this program, and I'm very proud of you taking all the issues ahead as AMOX Public Awareness Committee Chairperson. All the faculties, chairperson, panelists, and moderators, a very good evening to all of you. I would just say that as chair press committee, everybody has this issue, what these people are working. So we are working on 3 issues mainly: the breastfeeding promotion, benign breast diseases, and awareness, screening, and early detection of breast cancer, because this is the major killer of women in this last 2 decades, especially. It is even surpassing the cervical cancer deaths. At the same time, we are training, we are sensitizing the Foxians, updating their knowledge through various CMEs, updates, newsletters, and ready reckoners as well. We are training the paramedics, and we are writing the informative articles, making the rallies and marches for this public awareness, and we are organizing huge mass screening programs. So I think Charu will continue this work, which is continued to me even from the previous breast committee chairperson. I would say me and Charu have worked together, and we have taken up this work ahead. And I wish Charu all the best, and all the best for this webinar as well. Thank you so much, everyone.
Thank you, Sneha. I cannot imagine any breast committee webinar without you. So I'm sure that I will keep inviting you for each and every program.
Can I say something?
Yeah.
Charu, can I say something? Because I've joined from a mobile, I could not see. Now I see Taru, a very dynamic girl and a lovely friend of ours. And Taru, thank you so much. And I could see Dr. Komal, Dr. Anjali, Dr. Suyoga, Dr. Nirupama, and Dr. Vaishali Dattal, the president of Laturo Vaishwai Society, and Dr. Anjali. I just saw them while they were. So I just wanted to acknowledge them and send my love to them.
Thank you, Dr. Sunita, for taking out time for these minor details, and that is what will make you a great leader. Thank you so much, Dr. Sunita. And I think Yashodhara ma'am, are you around? I think madam had to leave. She has given her message. We would have liked to be blessed by her, but just her presence is enough to bless us. So with that, we conclude our inauguration, and I request Dr. Monica to propose the vote of thanks for the same.
Thank you, ma'am. I would extend a heartfelt thank you to each and every person who has taken the time to join this webinar. I would be thankful to Dr. Rishikesh Pai sir for giving his blessings, Dr. Parvechi sir for allowing AMOX committee to join with the FOXY committees and conduct a webinar. I would also like to thank the guest of honor, Dr. Sunita Tanduralkar madam and Sneha Huyar madam. Both of them are so appreciative that each and every junior person like me would like to work with them. Thank you so much, ma'am. I would also like to thank all the delegates and the faculties who have joined in. I am sure we will have a great scientific session forward. I would now like to call on Dr. Divya Vora, ma'am, to please conduct the session forward. Thank you so much, ma'am. Last but not the least, I would like to thank both the Vice Presidents, Dr. Yashodhara Madam and Dr. Alka Pandey Madam, and the Chairperson, PSC Committee, Dr. Priyankur Roy, for the same. Thank you.
Yes, I think the vote of thanks cannot be complete without me thanking Dr. Monica. Indeed, she's a treasure house of knowledge, passion, and willingness to work for the society and the committee. The speed with which she would do things, will really put any of us to shame, is what I thought. Monica, a lot to learn from you, for all of us also. And thank you for the instant cooperation that you gave from your side. And thank you for all the collaboration and the coordination that you did from your side. Thank you, Foxy, and thank you, PSC, and thank you, AMOX, for this opportunity. I cannot, the thank yous can go on, and I think we need to move ahead with the scientific session. So over to you, MOCs, for the scientific session.
So now we will conclude the inauguration. I would like to invite and introduce the other two MOCs with me, Dr. Pratibha Baldava. She's a consultant at the Baldava Neurosciences Hospital and Women's Hospital at Sholapur, and she has been the treasurer and the secretary of the Sholapur OBGY Society. She has published a number of papers in various journals. And Dr. Taru Chaya, she's a director at the Bansal Hospital in Jaipur. She's visiting consultant at Cocoon and Surya Hospitals and secretary of the Jaipur Society of Obstetrics and Gynecology. And she's a member at the FOXY Breast Committee. Over to you, to both of you all, to continue with the scientific session, please.
A very good afternoon to all of you and to the respected faculties. We shall start with our first session. I shall call the chairpersons for the same. The chairpersons for today's first speaker are Dr. Vaishali Dattal Madam and Dr. Anjali Ware Madam. Dr. Vaishali Dattal Madam is president of Latur OBGY Society and a very good close friend of mine. Abhishek, can we have the slides?
He has projected them.
It's already projected, ma'am.
Okay. I cannot see them actually.
She's director,
Okay.
Sarthak Hospital. And past
Dr.
treasurer.
Vaishali Tattal, Madam, is President of the Latur OBGY Society and past treasurer. She has conducted numerous pubectomy camps and conducted various educational workshops through Rotary and Logs. She's a faculty at state and regional conferences, and she has special interest in infertility and high-risk pregnancy. I welcome you, Vaishali, Madam. The other chairperson for today is Dr. Anjali Ware, Madam. She is president of Aurangabad OBGY Society and consultant at Ware Hospital, Aurangabad. She is practicing since the last 27 years in high-risk obstetrics and sonography. She conducted adolescent health camps in school and colleges, and she has worked in obstetric HDU. I welcome you too, ma'am. So I hand over the mic to y'all, and y'all can welcome the speaker, ma'am. Thank you.
Yes, thank you, Pratibha.
Yes.
First of all, thank you. Am I audible?
Yes.
Yes, ma'am.
Yes, ma'am.
Thank you, Pratibha, Priya, and Taru Chaya for giving me the opportunity to chair the session. It gives me immense pleasure to introduce Dr. Priya Singhal, ma'am. She has done diploma in advanced endoscopy at France. She is consultant in obstetric and gynec at Fortis Hospital, Jaipur, Golden Hospital, RG Stone Laparoscopic Hospital. She has been credited with APJ Abdul Kalam Appreciation Award in 2018, awarded of Excellence IMA WOW Delhi ISA, and Excellence in Field of Medicine IMA DMA North. Her special interest in high-risk pregnancy, breast and carcinoma cervix prevention. Over to you, ma'am.
Thank you. Honorable chairpersons, revered guests, esteemed faculty. I'd like to take this opportunity to thank Dr. Charulata Bapai for giving me this opportunity. I start my talk with a quote from Michelle Obama, who says, "There is no limit to what we as women can accomplish." Friends, there is no limit to what we as gynecologists can accomplish. Next, please. The talk is on management of mastalgia. Now, one would wonder, what can there be to talk about in mastalgia? Well, the objectives are to alleviate symptoms of pain. And there is a hidden agenda, and that is to identify those patients who are at high risk of breast cancer so that increased surveillance can be initiated. Also, whenever a patient comes with pain, she comes with an underlying fear of cancer. Hence, the third objective is to conduct appropriate investigations to rule out breast cancer so as to reassure the woman. Next, please. Breast pain is a very common symptom. About 45% of breast clinical evaluations are done for mastalgia, thus also providing us the opportunity to screen for breast cancer. Next, please. There are three types of mastalgia: cyclic, non-cyclic, and extramammary. Cyclic mastalgia occurs during the luteal phase of the menstrual cycle. Patient complains of heaviness, diffused bilateral pain. It can sometimes radiate to the axilla and the upper arm, and it is relieved by the onset of menstrual flow. Next, cyclic, non-cyclic mastalgia, on the other hand, is unilateral, localized, constant. It is caused by the inflammation of fibroadenoma, diabetic mastopathy, lesions like macrocysts, duct ectasia, etc. Next. Extramammary pain is due to chest wall muscular pains, trauma, pleuritic pain. Important to note is that angina can also present as extramammary pain. And another important thing is that 10% of breast cancer patients come with the symptom of breast pain only. Next, please. Etiology is multifactorial. It could be due to increased estrogen secretion during the luteal phase. It could be due to hyperprolactinemia, water retention, psychoneurosis, excess caffeine intake, smoking, aberration in lipid metabolism. Knowing these multi-factors can help us customize the treatment for our patient of mastalgia. Next, please. Now, how do we evaluate a patient who comes with breast pain? Well, any patient who comes with pain anywhere in the body, 4 pertinent questions should be asked. And those are what, when, where, and how. So what time of the menstrual cycle does she get the pain? When is it more? Is it during physical activity? Where does it radiate to, or is it localized? and how is it relieved, by medication or by the onset of periods. The patient is asked to maintain a pain diary for 2 months where she notes down the severity of pain, any leave or absence from work or school. Next. She is also given a visual analog scale where she identifies her pain with the emoji and tick marks the same. A score of 5 or more is important and significant for management of nostalgia. Next, please. Then after the pain, we ask her personal history, which includes her exercise, her dietary habits, smoking, alcohol. Important to note is the family history, where a history of breast cancer in first-degree relatives, especially if the breast cancer occurred before the age of 45 years, is very important. Also, history of ovarian, prostate, colon, and pancreatic cancers in first-degree and second-degree relatives should be asked for. Why? Because all these cancers share the same gene mutants. Drugs like OC pills and HRT can also cause pain. Next, please. The patient is then examined. Clinical breast examination will be taken by other esteemed faculty. So let's skip this slide. Next, please. Important to note during the examination is that the axillary tail should be examined and the patient should be examined. The chest wall should be examined laterally right up till the mid-axillary line, inferiorly right up till the subcostal area, also axillary, supraclavicular, as well as infraclavicular lymph nodes should be looked for, and examination should be done for extramammary causes like herpes zoster and costochondral tenderness should be elicited. Next. The investigations. We've taken the history, we've examined the patient. Now we come to the investigations. All patients, all women patients should have a mammogram after the age of 40. Ultrasonography can be done at all ages, and a core biopsy is done if there is a suspicious lesion. Next. Just like there are 3 fundamental rules to lead a good life, we have 3 fundamental tests. The clinical breast examination, imaging by mammography, ultrasound or MRI, and a core biopsy if indicated to rule out breast cancer. So once we've done that, next please. Once we've ruled out breast cancer, then the diagnosis of nostalgia is made by exclusion criteria. Next. Coming to the treatment of nostalgia, next please. The first line of treatment is reassurance, reassurance, and reassurance. We tell the patient we have done all the examination required, all the tests required, and she does not have breast cancer. So there is nothing to worry. This much kind of alleviates her pain and fear. Next. She is also counseled to do breast self-examination every month and come yearly for checkups. 70% of women wear ill-fitting braziers. So a well-fitting brazier is very important. It comes in the first line of treatment for nostalgia, and a sports bra is advised for exercise. Next. In an RCT, it was seen that avoiding caffeine, using simple analgesics, and a good exercise program, and the use of a sports bra alleviated the pain to a large extent. Diet should be low in fat, 15% fats only. Next, please. Next is phytoestrogens. They are plant-derived SERMs, and a well-researched group is isoflavones, like soya beans, chickpeas, tofu, sesame seeds. All these have, soya has been researched on, and it's been found to be very good for alleviating nostalgia pain. Next, please. Please keep pressing. Flax seeds, Nigella sativa seed oil. This is our own Kalonji oil. A good RCT was TB PCT was done on Kalonji oil, and it was found to be as effective as diclofenac gel. Next, evening primrose oil, vitamin B6 and vitamin E play no role and should not be misused. Next. Low intensity laser therapy is many times useful. Next, please. Coming to the pharmacological treatment, NSAIDs. The non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, diclofenac acid, we hesitate to use them very often, but they should be used. They are least toxic and they work both for cyclic as well as non-cyclic mastalgia. They are about 80% effective. Topical NSAIDs also form the first line of treatment and their benefits outweigh adverse reactions. Again, diclofenac and piroxicam gel is very effective both for cyclic as well as non-cyclic pain, and they are a reasonable alternative to oral NSAIDs. Next. SERMs. This is a very important slide. Selective estrogen modulator receptors work by blocking estrogen receptors. Two SERMs, tamoxifen and centroman. So tamoxifen 10 milligrams per day for a period of 3 to 6 months is about 80 to 90% effective in controlling mastalgia, but there are side effects like irregular periods, endometrial hyperplasia, hot flashes, but it is the drug of choice if the first line of NSAIDs and fails. Centroman is a made in India product and it is said to be very effective. A lot of studies have been done in AIMS and elsewhere. A dose of 30 milligrams per day for 12 weeks is very effective. And the best part is that there are no side effects like irregular cycles or thromboembolic phenomenon or so this is a very useful drug and should be used. Next, please. Next. So bromocriptine, bromocriptine can be used if there is prolactinemia and diuretics, if there is water retention. GnRH analogs are used if nothing else works, and it should not be used for more than 6 months. The side effects are hot flashes, vaginal dryness, oily hair and skin, like we all know, and a backup of HRT might have to be used in case we have to use it for more than 6 months. It forms the second line of therapy. Next, please. Danazol is the only drug which has been approved by the US FDA, ironically, but it has virilizing side effects, so it doesn't come much into use. But yet, if nothing else works, then we have danazol. Sometimes just withdrawal of OC pills and HRT is good enough. Next. For non-cyclic pain, sometimes aspiration of macrocysts under ultrasound guidance works. There is no role of surgical management. Next, please. Finally, relaxation therapy. Relax like your life depends on it. Next, please. To conclude, rule out breast cancer by triple assessment tests, reassure the patient, advise her a well-fitting garment for breast support. NSAIDs and topical NSAIDs gel work very well. Second line treatment is centroman, tamoxifen therapy for 3 to 6 months, GnRH analogs for severe refractory cases, vitamins, GLA, and primrose oil are not effective. Next, please. Thank you so much for your attention. Thank you. Dr. Charulata, please unmute yourself.
So I think we'll take our chairperson's comments for the same. Dr. Vare is there? I think, is that chairperson here? I think, Dr. Divya, that was an excellent talk. And probably, as you rightly said, mastalgia is probably one of the most common symptoms that we come across. And women are extremely worried that whether it is malignancy. And the thing is to relieve them of this fear. So what is again more important is that only examination may not suffice. And we would have to probably do either an ultrasound and or a mammography for the patient. You take this opportunity to make sure that she gets screened. We think that it is always a good idea that she's come to you with a breast problem. Just make sure that you undergo some kind of screening procedure for her. And then, you relieve yourself as well as her that there is no problem. And the second thing which I would like to say is that the Centroman, the brand name Sevista, that is something which we all need to use much more. not only for our AUB, but also for breast problems, but because mastalgia gets treated and cured so fantastically. I think we have Dr. Sharmila, we have Dr. Girija here. We could take an inputs from both of them regarding mastalgia. Dr. Girija?
Yeah, actually, one of the most important thing is corrective breast wear. According to me, what Madam Divya Singhal said was very important, because many times patients have postural issues and wrong, breast support systems that they wear. That is one. And the second most important thing is, as you mentioned, yes, onaloxafen or an SERM can be of great help in patients who are very reluctant. But I will always start with a supplement of a primrose oil, or some sort of a pyridoxine and a belong typical combination, or give them some sort of vitamin B, tell them to sort of stop coffee. And I look at it as an opportunity of screening them, as you rightly said, Charu, because we all belong to Pune, especially you and me, where the highest cancer in Pune is breast cancer. I must share this with you, that the topmost cancer is breast cancer, and it is seen to be affecting women in the age groups of 35 to 45. So even before women are aware of cancer cervix to an extent, but breast cancer is something which is stopping, and the best way of diagnosing, we have understood, is self breast examination. So educate women to examine. They come presenting, there's something I feel in my breast, doc, and then from there all the story starts. So none of them have gone through any regular screening of mammography, sonography, or anything. Charu, I think you have the similar kind of an experience.
True that.
How we detect our young women with breast cancers currently.
True. So that was a great input. And Charmila, would you like to Charmila?
Thank you, Charu. It's actually what Girija was saying, like you take the opportunity to screen her, because many times we think that painful breast will not have cancer inside. So never have that misconception, and use it to ask her to screen herself and tell her the proper protocol, because she may come to you once and may not turn back in the next years. So I have to tell her very clearly that has to be done, because more obesity has become such a big problem, and dense breasts are really a problem for even the greatest screening too. So she's not going to undergo, it's going to cause lots of problems. And as Girija said, I would like to start with supportive bra for her, so that she does not have that postural problem for fibroadenosis proved, and then probably give her evening primrose oil. It seems to work in a great group of patients. It need not go to higher drugs, but ormeloxafen, centromon is really a good drug for fibroadenosis. That also you cannot give it for a prolonged period of time, because it's known to cause thrombosis. DVT is common when you use it for prolonged years. So it should be like a change of her lifestyle, so that she at least reduces her weight, keeps her coffee and tea under control, and screens herself, and has to take it on and off. Whenever she's got problems, take evening primrose oil, switch over when she has a bigger problem like that. So that will make a better scheme of things for people with a painful breast.
Smoking also under control. Smoking is quite rampant in urban bound women, that also causes
active and passive, both forms, I agree. Thank you so much. That was some great interaction that we had. Over to you, MOCs, for the next session. Dr. Taru?
Thank you so much, madam. Now we go on to the next speaker. May I call upon the chairpersons for the next speaker? Our chairpersons are Dr. Komal Chavan. Everybody knows Dr. Komal very well. She is the chairperson of Medical Disorder Committee. Madam has been the chairperson of MOX Family Welfare and MTP Committee, member of Managing Council MOX, and a joint secretary ISOPAB Mumbai chapter. She has also been the premises secretary for AFG and a national expert for FOXI UNICEF Lakshya project. The other chairperson for today is none other than our Solapur Obstetric Gynec Society president, Dr. Anjali Jamma madam. She is a consultant at Jamma Hospital and Laparoscopic Surgery Center since 2000. It is her first laser gynecology center in Solapur and nearby district. She has had special training in ultrasound and laparoscopy. She is well trained in laser training in cosmetic gynecology, and her main area of interest is also the same. She's been invited as faculty at many of the conferences. I hand over the mic to the chairpersons now. Thank you, madam.
Thank you. Thank you so much, Dr. Pratibha, for the kind introduction. And at the outset, I would like to congratulate my dear friend Charu. I think Charu Bappai has taken over the breast committee and she's doing real wonders. Organizing such focus program. I can see the enthusiasm and zeal in her before she became the chairperson. And she's definitely going to take the committee to the great heights. So all the best wishes, Dr. Charu, and also Dr. Monica, the Public Awareness Committee of EMOX. And now I have a proud privilege to introduce Dr. Girija Wagh. And we all know Dr. Girija Wagh as a professor, Department of Obstetrics at Bharatiya Vidyapeeth Medical College, Pune. She is the Vice President-elect of FOXI. And I have a very close association because she also belongs to the FOXI Medical Disorders in Pregnancy Committee, having been chair of the committee from 2012 to 16. And she's Vice President of India Chapter of Gestosis, member of the Governing Council of ICOG 2011 to 14, Assistant Coordinator for National Eclampsia Registry, and she has also been the mentor for Lakshya, MOH, FW, peer reviewer of many journals, including the Jogi, BJOG, and she has so many awards and numerous publications to her credit, and also the regional director of Steady Medic. I think her teaching is her passion, and we are really eagerly waiting to hear from you, Dr. Girija Wagh. So over to you, Dr. Girija Wagh.
Oh, thank you so much, Komal, for that wonderful introduction. And thank you, Jamma Madam, for being here to chair the session. Dr. Anjali, I'm sorry I've been dodging your invitation so often, and I promise that I'll come to Sholapur. At the outset, I would like to congratulate Charu for bringing this entire webinar together. I hope my slides are seen. Are they seen?
Yes, they are clear. Yes, ma'am.
Yeah. So thank you, Dr. Charu, for bringing us all together here on this webinar. And I think webinar is the best thing because we can connect through our offices and we can connect to so many people. And I hope I'll be able to make justice through whatever has been given to me as a task by you, Charu. And abnormal nipple discharge is something that we really, many of the times, we face it as gynecologists because patients trust us for their breast-related issues. And naturally, then we are left at, a sort of a question as to how am I going to deal with this breast discharge. Now, it's the third most common breast-related complaint, and after breast pain and breast mass, we just had a talk on mastalgia. And 80% of women will have an episode of a nipple discharge during their reproductive age group. And thankfully, most of them are benign in origin. And the primary goals of evaluation and management are to differentiate patients with benign nipple discharge from those who have an underlying papilloma or maybe a high-risk lesion or cancer, and to manage patients with underlying pathological nipple discharge. While I'm saying this, I must also tell you that not many cancers would present with nipple discharge, and that's a problem. And most of the discharging ones would be benign. Now you can see here in the picture that there can be an intraductal papilloma also, which can be just a simple benign growth in a single milk duct in a woman, and that can be giving rise to the discharge. So today we are going to look at the types, how to evaluate and manage this common problem. And we are not going to deal with any surgical management, and I would conclude with an algorithm for approach. Now we all know that normal milk production in the form of lactation, physiological nipple discharge in the form of galactorrhea can be present sometimes in a few women, or it can be a pathological suspicious nipple discharge. Sometimes galactorrhea can also be a result of hyperprolactinemia or certain other secondary causes such as some medicines that the woman is taking. Now we know that lactation is a normal secretory product of the breast, that is milk and colostrum, and during pregnancy and the postpartum period, the mammary glands will develop and produce milk in response to several physical and biochemical forces, and it can continue for at least 6 months after delivery, after cessation of breastfeeding. And today the WhatsApp University has educated women. Most of my patients are trying and attempting to feed their babies for 2 years, and that's something nice. So they will be continuing to have this breast secretion. Now, galactorrhea is defined as non-pathological nipple discharge unrelated to pregnancy or breastfeeding, and is usually manifested as bilateral milky nipple discharge involving multiple ducts. And although it's usually bilateral, white to clear, may also be unilateral, and a variety of other colors, including yellow, green, brown, or gray, but not bloody can be present. And it is very commonly caused by hyperprolactinemia, which may be secondary to medications, pituitary tumors, endocrine abnormalities, or other medical conditions. Now, pathological or suspicious nipple discharge are the secretory production of fluids other than milk, which may be due to a pathological cellular process in the breast. And this discharge is usually unilateral, localized to a single duct, persistent and spontaneous. It can be serous, that is clear or yellow, sanguineous or bloody, or serosanguineous, which is blood tinged. And common etiologies of pathological nipple discharge include papilloma, DCIS, and so on, and we'll look after each one of them. Now, papilloma happens to be the most common cause of pathological nipple discharge in a benign, and it's usually found in 50 to 57% of the women, is a papillary tumor growing from the lining of the breast duct. And the discharge associated with a papilloma can range from clear to grossly bloody, and solitary papillomas can occasionally harbor areas of atypia or ductal carcinoma in situ, and therefore they have to be treated or approached properly. Now, there's another condition, that is duct ectasia, which is another common benign cause of pathological nipple discharge. In approximately 14 to 33% of pathological nipple discharge cases, and you can see that this is a normal duct here. I'll just get my pointer. This is a normal duct here, and this would be a dilated and a clogged duct that you can see here. Now, cancer would be found in 5 to 15% of cases of pathological nipple discharge. And the most common malignancy associated with nipple discharge in the absence of other findings is the DCIS. And if you're lucky enough, you can find it and treat it early. But sometimes you may have different stages and phases that would come by. Now, infection can be a cause, especially when there is a periductal mastitis or a purulent nipple discharge. And therefore, clinical evaluation is very important, where you take a thorough history, do a physical examination, and this should be performed in all women in non-lactational nipple discharge, or to determine if it is physiological or pathological. Now, the clinical history is most helpful in distinguishing physiological from pathological nipple discharge, and a complete medical history should be obtained with specific areas to address. Now, what is very important is the appearance of the discharge, frequency of the discharge, whether it is spontaneous or provoked by manipulation of the breast and or nipple areolar complex, and whether the discharge is unilateral or bilateral and uniductal or multiductal has to be established. Physiological nipple discharge is usually bilateral and multiductal and occurs with breast manipulation. Conversely, the risk of cancer is higher when the discharge is spontaneous, bloody, unilateral, uniductal, associated with a breast mass, and or occurs in women over 40 years of age. I would like to modify this, even younger women, we have to be a little careful. A history of recent trauma should be elicited, and the trauma can include mammographic imaging with compression as well as vigorous manipulation of the nipple, recent onset of amenorrhea or other symptoms of hypogonadism, hot flashes, vaginal dryness should prompt consideration of hyperprolactinemia. So these can be a part of your thorough clinical evaluation, which you can approach the woman with. Now, several cases or classes of medications can cause hyperprolactinemia. Many times women are not very ready to disclose and tell you that they are taking antidepressant medicines. So you should proactively ask them this question. And anticoagulants can also cause bloody nipple discharge in patients who sustain trauma to the breast, even that as a mild as mammographic manipulation that would come. And sometimes the classical mammographic manipulations sometimes can be extremely traumatic to patients, giving rise to a nipple discharge. And while I was speaking on infection, I must also remind you all that being in India, we should always start looking at any kind of breast lesions which are infectious in origin and have a differential, whether it's a tuberculous breast abscess, because many times even that can happen. In whatever 30 years of practice, I complete today 30 years of my clinical and academic practice. Today I started it formally, and I've seen about 2 patients who have presented with tuberculous breast masses, which were actually abscesses. Now, complete breast examination should be performed as detailed, and the specific goals of the examination are to be followed, like note the symmetry and contour of the breast, position of the nipple scars and vascular pattern, as well as any evidence of skin retraction, dimpling, edema or erythema, ulceration or crusting of the nipple, and changes in skin color. The skin covering the breast and the nipple areolar complex should be examined for lesions that may be staining the woman's clothes and mimicking the nipple discharges. Some examples can be the Paget's disease, insect bites, local infections, and eczema, and suspicion skin lesions should be biopsied. It's very important to document all this correctly. So detect the enlarged axillary or supraclavicular lymph nodes, mention them, delineate and document breast masses, identify localized areas of tenderness and relate them to areas of pain noted by the woman and no other physical findings. And women with bilateral discharge, the physical examination should include checking for a chiasmal syndrome, that is bitemporal field loss, and signs of hypothyroidism or hypogonadism we have to look for. Now, there are various ways in which imaging can be performed, and especially mammograph and ultrasound, and I'm going to tell you what are the typical guidelines that are there in context with these approaches. Women more than or equal to 40 years should undergo both diagnostic mammography and focused breast ultrasonography. Patients who had a recent mammograph, that is under 6 months, or are pregnant may undergo breast ultrasonography alone. And mind you, even during pregnancy, there are patients who are presented with breast cancers. Immediate post-delivery, there can be. And therefore, we have to be very, very sensitive to complaints with which the women come to us. Women between 30 and 39 years of age should undergo diagnostic mammography first, followed by breast ultrasonography if necessary. And women less than 30 years of age should undergo breast ultrasonography first. Mammography is only performed if the initial ultrasound shows a suspicious finding, or if the patient is genetically predisposed or has a hereditary breast cancer. And today we also have a genetic testing which can be performed for these women. So we are fortunate right now, which can be offered to women in case they have a very strong family history of the same. Now, mammography, digital with or without tomosynthesis, is the first line imaging modality for evaluation of pathological nipple discharge in most practices. Although it is the best modality for identifying suspicious lesions, mammography may fail to show cancers or high-risk lesions that are small, lack calcifications, or entirely intraductal. And the sensitivity and specificity of mammography for detection of cancer or high-risk lesions such as papilloma or atemia ranges from 7 to 10 and 94 to 100% respectively. And therefore, we have to be very, very driven by our physical and clinical assessment. Focused ultrasound provides a useful tool for the diagnosis of ductal disease, as it is directed to the perioral area and provides visualization of dilated ducts and any nodules inside them. It's especially useful for identifying lesions within the mammary ducts, and it allows visualization of ductal pathology as small as 0.5 mm. And we have very, very high resolution ultrasound machines nowadays with good breast probes, and they can be of great help. And when evaluating pathological nipple discharge, ultrasound can identify 63 to 69% of lesions not visible on mammography. It also is used to guide percutaneous biopsy of lesions and or wire localization for surgery. Although ultrasound is more sensitive than mammography, it is less specific in differentiating benign from the malignant lesions. Now, patients with pathophysiological nipple discharge but negative mammogram and ultrasound may undergo breast magnetic resonance imaging. And this is a relatively sensitive imaging modality with moderate specificity. And a contrast-enhanced MRI has demonstrated 93 to 100% sensitivity for invasive cancers, as well as benign papillary lesions. However, specificity has been reported to be as low as 37%. Others can be galactography, ductoscopy, cytology. Sometimes we are tempted. I have also done it so many times in my patients, but I've realized with a lot of pain that it doesn't help. And it's not useful because most of the times you will not be able to differentiate anything because these are already lyse cells. You cannot even diagnose whether it's atypical or there could be a lot of apoptotic cells there. So it's difficult. Breast biopsy and skin punch biopsy is something that has to be considered as swiftly as possible because the tissue diagnosis is going to help us take the direction forwards. So as I had mentioned that we'll be looking at an algorithm at the end of my talk. And this is the algorithm where you talk of a non-lactational nipple discharge. Is there a palpable mass on clinical evaluation? Is the question you ask. If it is so, then evaluation of the nipple discharge in the setting of a palpable mass does not differ from that of a palpable mass without discharge. And you can have, actually, there's a wonderful write-up and up-to-date. If you want, I can share it with all of you. Does the nipple discharge have any of the following characteristics? Unilateral, bloody, associated with a mass or skin changes? If the answer is yes, then pathological discharge, women more than 40 mammogram plus ultrasound, women 30 to 39 mammogram or ultrasound may or may not be done, less than 30 ultrasound first and then mammogram, and men of any age mammogram plus ultrasound, plus breast MRI if negative ultrasound and mammogram is seen. Now, physiological discharge, if there is galactorrhea, ensure screening mammogram for women equal to or more than 40, medical evaluation and treatment for hyperprolactinemia and other causes of galactorrhea. If there is a suspicious lesion, core needle biopsy with clip placement, that is for finding it out or identifying it. Malignant, cancer treatment, benign surgical excision of the lesion. If the discharge stops, no further intervention persists, surgical excision of the discharge duct to relieve symptoms. And if there is no suspicious lesion, you will follow surgical excision of the discharging duct to relieve symptoms. So this is what I have to say about the abnormal nipple discharge. And with this, I say thank you. I hope I have been able to make justice to what task has been given to me. Thank you so much.
Thank you. Thank you, madam. As usual, your talk was really excellent with crisp take-home messages.
Thank you.
I think that it is a very, very important topic that Dr. Girija has covered so beautifully. And I think what happens is that very often you just have to think of all the red flag signs associated with abnormal nipple discharge. Firstly, if it is bloody, if it is from a single duct, and if you feel a lump. I think these three will probably be the red flag signs for any abnormal nipple discharge. But if it is bilateral and it is greenish or a little bit of yellowish colored, then and it is from multiple ducts, then it is very often it's going to be a benign kind of a discharge. So we just need to have our red flag signs in place, which Dr. Girija has so rightly told us. And one more point I would just like to mention is about the ductoscopy. I think in bigger hospitals in Mumbai and many other places, and in people doing exclusive breast cancer work, they do have a ductoscope, which is a very fine scope, which they can actually scope the duct and look for the presence of these intraductal papillomas. So these are just one or two thoughts I thought we should just highlight upon. And Dr. Charmila, you would want to
Charu, I was also going to speak about the ductoscopy only because I've heard some of the people doing about it. And this is very focused, and now it is the need of the hour because we are getting so many people coming up now with all the discharge. And if we have modalities to our armamentarium, we should use them accurately. So this is a new thing in which they can see the duct, whether it is a blocked or there is any pathology in the duct, and that can be well seen. So I think Dr. Girija has completed every aspect of it, the screening, counseling, and how the management, everything. So excellent talk, and I'm waiting for Charmila's comments.
Thank you, Komal. It was a wonderful talk, Dr. Girija, as always. There are certain points which actually need emphasis on from her talk, like do not miss the drug history. She may be taking a drugs like ranitidine for a long time. That can cause a discharge, and many times people will not even think about ordinary drug which is causing discharges. And the other one is tuberculosis of the breast. It's quite common. It's not as rare as.
I think we lost Charmila.
Yes.
Till that time, Charmila comes back again about the ductography and the galactography that ductoscopy I mentioned. Currently, the status is it is in the phase of evolution, and it is yet not identified as a gold standard. But yes, I think it has a promise down the lane. Correct. So that we can identify, at least know that it's benign or malignant, and then take, because mastectomy turns out to be a very, very debilitating approach if it turns out to be benign later on.
Once upon a time, mastectomy was the only thing available for abnormal nipple discharge. Yeah. So today we have all these newer modalities which can help us reach a diagnosis, and obviously saving breast along with saving lives does a lot of benefit to the patient's psyche also. So I think that, these newer
As
modalities.
always, Charu, I may be a little repetitive, but I want to share this because I've had the privilege of being on your 2 breast programs. But I like to say this because there are again newer friends here on the forum.
Yes.
That the Tata Institute sometime back, because I was very fortunate to be part of one breast screening workshop long time back.
Okay.
At cancer screening program. That was for 3 days, and that time I remember they had conducted a study in Mumbai, and they identified one component of the city where they gave actual supplements to women there, where they were giving concentrates of folates and folic acid, which is similar to green leafy vegetables, while other women in the other area were studied as a comparison. This was a case control study. And they observed that there is a remarkable reduction in the breast cancer occurrence in these women. This was a very small study, but it left such an impact on my mind that when Dr. Charmila is saying about obesity, which is a huge problem currently, giving rise to so many other diseases, we must insist on proper health care for women whenever we get an opportunity about weight modification, weight loss, diet, and using, proper breast clothes. Because even one of the studies has shown that very tight clothes, which women aplyakade kamala, women who come to us as maids and assistants, are wearing tight blouses since morning till night. And even that can cause, issues. So whenever we have an opportunity, I think we can just speak to women about preventive breast health as much.
Right. Fantastic. So Komal, thanks a ton for being here. And best wishes to all your further endeavors. We support your candidature as for vice president, for the post of vice president West Zone. And we would like to see you more often on our webinars. We shall make it a point to have you with us and have your precious comments for the same. Thank you.
Thank you. Thank you so much, Charu. I'm on the way, but I made it a point that I will definitely be
Yes, you
there.
had mentioned so. Thank you very much. Yes.
Best of luck, Komal. Best of luck,
Thank
Sneha.
you.
Best of luck, everybody.
Thank you. Thank you so much, Dr.
There is this,
Girija.
Dr. Priyankur has joined and we have to take his sound bites because
I'm sorry, I tried joining before but couldn't join. Yeah, Komal ma'am, as everyone was wishing you again all the best wishes, ma'am. And I'm really thankful, I must say, to Charu ma'am for giving the Public Awareness Committee a chance to be part of this webinar. And I thank Monica as well from the AMOX side, as well as an integral part of the Public Awareness Committee for doing all the hard work that she's putting in. So Charu ma'am, congratulations, excellent program, and thanks for having us here.
Congratulations to us, Priyankur. At last we did a program together. So it's always a pleasure working with you and your team. Thank you so much.
Thank you.
Many more to go. Thank you. Well, there's a small change in the program. Dr. Charmila needs to leave a little early because of her ICOG Governing Council meeting. And so if it is okay with our moderators and the other people, is it okay if we take the panel before the talk? Dr. Shaila?
I have no problems.
Thank you so much. So Dr. Taru, I think you can go ahead with the introduction of...
Okay, ma'am.
Okay. Yeah. Please.
Hello. Good evening, everyone.
Good evening, ma'am.
So now we have a panel. Something solid of any size and shape is lumps and bumps. If breast becomes rough or irregular or uneven, it's important to evaluate. And so we are here for. So we have to start our panel. I'll introduce my moderator. It's my privilege to introduce Dr. Charu. She's Director, GEMS Hospital Endoscopy Center in Ashwin Hospital, Pune. Now, current chairperson, study on female breast committee policy. And so many awards has been in her lab.
And part of the entire breast committee. And we are so fortunate to have Dr. Divya, Dr. Taru, and so many fantastic warriors against the fight against the breast cancer. So Taru, thank you very much. And thank you for being here. You're always a great support of the breast committee. Thank you.
Next moderator is Dr. Rashmi Kharotkar Kahar. She is chairperson of AMOX High Risk Pregnancy Committee. She was organizing secretary AMOX 2020 and joint secretary ISOPAP
West Zone Coordinator, Breast Committee, Foxy. She's been gold medalist many times. Emergency Ops is her passion. Foxy Tank Award, Diru Shah Trophy Award, and many awards during her secretariatship. Welcome, Dr. Rashmi, because we are all short of time. Please, sorry, I am not going to read everything. So I'll request our moderators to introduce our panelists.
Can you even introduce our expert for today?
Okay. Dr. Charmila, ma'am, I'm privileged to introduce you. She's Vice President-elect Foxy 24, Chairperson Clinical Research Committee Foxy 16 to 18, National Coordinator UNICEF Foxy, National Coordinator MEDA Foxy PG Program, National Coordinator is SAR Gurukul 22, WHO SARO MDSI India member, past Secretary Trichy, and President Menstrual Hygiene Management Committee 18 to 20. Welcome, Dr. Charmila, ma'am.
Thank you. Thank you, Dr. Charu.
Dr. Charu, will you introduce a panelist?
You could say a word about them, yes, please. You can just add one line.
Our panelists are Dr. Varsha Lahare, please. Abhishek ji, please. Yeah. Dr. Varsha Lahare, President, Nasik OBJ Society, Zonal Coordinator, MOX, and she's past President Secretary, past Joint Secretary, and Director of Prayag. I'm not able to see.
She's the Director of Prayag
Hospital,
Nasik, and a very good friend.
Yeah. And
Dr. Manisha Ghate,
Manisha, West Zone Coordinator, Food, Drug, Medical, Surgical Equipments. She's working as consultant in Ghate Surgical and Maternity Hospital. Next. Dr. Anuradha Garar. She is President, Osmanabad OBG Society and Director, Garat Hospital, Osmanabad. Next. Dr. Seema Patel. Her special area interest is critical care obstetrics and very good hobbies, gardening, traveling, and she is at present President, Jalgaon OBG Society. Next. Dr. Chavan Rajendra Tilal. He has received many esteemed awards from Organization for Blood Donation and Family Planning Program in rural areas. And at present, founder of Maharashtra Blood Bank serving rural areas, founder of Kanta Maternity and Surgical Nursing Home. Next, Dr. Vanna Gadi. She is consultant OBG, sonologist and endoscopy surgeon, founder Female Fetus Protection and Safe Girls Council Center, Cluj in July 1992, and President OX. She was in 2018 to 2019. Member of Contraception Family Planning Committee during 18 to 20 of MOX. Next, Dr. Priya Shinde, consultant OBG Society in Shinde Multi-Speciality Hospital, Chandrapur, and Secretary Chandrapur OBG Society. Awarded MS Signature International Award 22 for extraordinary contribution in the field of maternal and child health under Rural Health Mission. Next.
Yeah, so that is our very esteemed.
Very short.
Yes, very true. Our esteemed expert and our extremely fantastic panelists, Dr. Rashmi. Is Rashmi here?
Rashmi is probably in an emergency. She said she'll join as soon as she can.
Oh, okay. Okay. So, thank you, Dr. Taru, for all the kind introduction. And now we move ahead to a very interesting panel discussion, lumps and bumps in the breast. Let's get it on screen. Dr. Charmila, are you, who is our expert, and our panelists are Varsha Lahade, Anuradha Garar, Manisha Ghate, I think is unable to join, Dr. Priya Shinde, Dr. Rajendra Chavan, and Seema Patil, as has been introduced. So the breast is indeed an organ of growing concern. The form, function, and pathology of the female breast are major concerns of medicine and society. As mammals, we want to, the breast is going to nourish the young, The breast contours occupy everybody's attention. As obstetricians, we seek to enhance or diminish its function. Sometimes, when she's lactating and she doesn't get enough milk, we have to try to increase the secretions. And unfortunately, if she has lost a baby, we need to decrease the work of the breast. And as gynecologists, the appearance of any inappropriate lumps and discharge is going to worry us because it can signify serious disease. The discharge part has already been very well covered by Dr. Girija Wag. And so now we move on to the lumps and bumps in the breast. So a very warm welcome to each and every one of you. The objective of today's panel discussion, we're going to discuss about the various kind of breast lumps that can occur. We're going to see how we can either exclude or confirm malignancy, provide a diagnosis to the woman, and provide an explanation, if possible, as to why this has occurred to her. Friends, what is important is that benign breast diseases account for 80% of all breast pathology. But every lump in the breast must be treated as malignant unless proved otherwise. I think this is the bottom line or the dictum and a very important take-home message, that we have to make sure that we prove that it is benign. Otherwise, we have to consider it as a malignant. Let us just talk a little about the basics. The breast is divided into 15 to 20 lobes by septae. Each lobe consists of fibrofatty tissue and glandular tissue. There is a lactiferous duct, which is lined by cubical epithelium, which is going to drain every lobule. Each duct divides and subdivides and ultimately ends in the alveoli, which is lined by a single layer of milk-secreting epithelial cells. And there is a rich capillary network, and there are myoepithelial cells which surround the alveoli. So when we get a lump, it can be either from the fat, it can be from the lactiferous duct, or it can be through the myoepithelial cells, or it can be through the alveoli. And so we have to find out from where exactly these lumps have arisen and how we are going to handle them and manage them. So Dr. Varsha, dear friend, we would want you to start off with the opening batsman. We are going to talk about breastfeeding issues also, which can give rise to lumps in the breast. And so we have this 32-year-old lady who's undergone a full-term LSCS for fetal distress just 10 days back. The baby is doing very well. And here she has come to you with a severe throbbing pain and lump in the left breast. So how will you proceed? What all is the history? What all we are going to examine? What do you think it is at first glance? Over to you.
Hello.
Yes.
Yeah. Looking at this patient, she's postpartum day 10. So she must be breastfeeding or she may not be breastfeeding. So I need to ask her what is the status present, whether she's feeding the baby or not. 1 second, I have to ask the history of fever of any kind, chills along with it, and when they started, when was the pain started. Third, whether there is any lump there. On examination, I should look for the color of the skin. I should look for the swelling in the breast. Is it localized or is it generalized? So these are all things I have to examine. I have to look for the nipples, whether they are cracked or whether there is any injury. And now after the injury, whether she's feeding or not feeding, that also matters.
Yes.
So, and the engorgement of the breast is looked for. So all this goes in favor of mastitis, ranges from mastitis to breast abscess in postpartum.
Perfect. So I think it is extremely important, mostly is that, whether, she is breastfeeding her baby or she is not breastfeeding her baby. Very often we see cases wherein the family tells her that the first few days you don't have to breastfeed, it is not proper milk. And, she's discouraged from breastfeeding. Again, she's undergone LSCS. We don't know whether, she has been in a, breastfeeding friendly hospital where the baby has to be put immediately to the mother's nipple, or whether it's a normal C-section, and what is her course of breastfeeding. But looking at this entire situation, it looks as if she has as a breast, because on examination you found a tense, tender, hot, fluctuant lump, and the right breast also appears to be engorged. So now we have tentatively reached a diagnosis of breast abscess with an engorged right breast. And this is exactly how these engorged the breast abscess looks like, with some pus dripping out from the nipple also. And I'm sorry. The most important thing is that, do we need to do any investigations, Dr. Varsha? will you investigate any further? You can see
Definitely.
things.
I would look for complete blood count. What is the status of a hemoglobin? Then.
Varsha, you have to unmute your screen.
You have unmuted. Am I audible now?
Now you are audible. Now you are audible.
Yes.
Yeah, we have to do a complete blood count for WBC as well as our hemoglobin status. And second, a proper examination. You have to diagnose the location of the abscess. Very important. And I don't think mammography is needed. This is simple clinical diagnosis.
So, Dr. Charmila, would you advise that we do an ultrasound in each and every case like this? What do you think?
No, it's not necessary. When you have a clear-cut diagnosis of she didn't have anything 10 days back, and after she's delivered and she's lactating, she's having a problem. I think you should not over-diagnose also. Do not overuse technology beyond a point.
Yes. That is very rightly said, because here it is a visual, diagnosis, absolutely, a diagnosis. And all of us, as obstetricians have been dealing with this problem day in and day out, and our eyes and our hands are well trained to diagnose this particular condition. And so ultrasound is not really necessary. Only if it is a very deep-seated kind of an abscess or it's a very large breast, we may have to do an ultrasound for the same. So,
I just wanted to add, you have to do a fluctuation test that we do it with the fingers. One, if it's a hard mass, think of antiboma, because she might have taken lots of antibiotic, and then you feel the antiboma differently.
Yes.
It is little firmer.
Yes, absolutely.
Yeah,
Dr. Anuradha, would you like to continue and let us know how you would want to, move ahead in this particular case?
Now we have to look for the breast abscess, which is on the left breast. So for the left breast, we have to go for incision and drainage, followed by the packing. And for the right breast also we have to take care, because there is an engorgement. So we have to give antibiotic drugs, and also we have to give some drugs to reduce her erythema. We have to advise the patient that she is supposed to continue the breastfeeding.
Some other opinion also, Dr. Priya. What do you think you would want to do in this case? Like whenever you have a breast abscess, I agree it is a significant abscess which we can see. But do you think that, what would be your call in this particular situation?
Thank you, madam, for the invite. If the diagnosis is clear-cut, if it is very big, if the fluctuation is positive, then we can go ahead with the incision and drainage. Because
Carmila, you would want to add something over here, or what do you think? Like, do you think IIT is recommended? Do you believe in aspirations?
No, somehow aspiration I'm not comfortable with. I would rather put her under sedation, proper sedation, and do an IND. I don't know, you have mentioned about aspiration, but I don't have an experience of repeated aspirations. No.
But aspiration is needed if there is a doubt, then we can go for the aspiration.
And sometimes you have to break out so many of those. The abscess won't be a single abscess. It will have lots of loculations inside. So we need to break everything to remove.
This is a study which is published Indian Journal of Surgery 2012, quite an old one. And what they mention is that surgical drainage of breast abscess, even if it's a large one, can be replaced by repeated needle aspirations. Why? Because it avoids surgery, it is minimally invasive, avoids hospital admission, milk fistula formation, unsatisfactory cosmetic outcomes very often. And they believe that ultrasound guidance to drain this particular abscess with a needle can go a long way. So very often you have ultrasound guidance, even if they are loculated, we give a little bit of local anesthesia and we can drain it. So many studies today are talking about this kind of needle aspiration rather than an IND. And we have Dr. Mangala Vani in Pune, who's a very big, proponent of this kind of repeated needle aspiration. She treats all her patients with these kind of needle aspirations. And I think at least what we can do is, if it's a small kind of an abscess, if it's we have to make an effort, I think, to try these needle aspirations, which we have started
this
now.
is a big one, right? You showed a picture.
Yes,
of
I
the
agree.
big abscess.
I agree. But they claim that even if it's a large one, you can replace it, and only if it doesn't work, or if you feel the patient cannot come for repeated needle aspirations, an IND can be done.
Maybe a good option, because sometimes when you do those IND, there's a big cavity inside, and the packing and the trauma that the mother undergoes for days together, with the pain and everything, probably.
And I think many of us have seen the very ragged and bad scar which is left behind because of this. So in the West, I think they are very much only into repeated needle aspirations. I've had many patients coming from there. They told me about these kind of small abscesses or small lumps, milk lumps as they call them, where she underwent only repeated needle aspiration, and she did well with it. So I think this is a matter of little interaction and discussion which we could have. But what we have to realize is that the studies and many articles today are moving towards these repeated needle aspirations. So I think we need to make it a habit. We need to make it a point. Probably next time we can have a small workshop wherein Dr. Mangala Vani, who has had a big experience with this, can maybe demonstration may not be possible, but can tell about her experience with this, and we in our hospital also. Dr. Chavan, you want to say something?
I just wanted to tell one thing.
Yes.
The abscess is there. Once we feel that it is there, we need to see whether it is organized or not, or whether it is pointing towards the surface or not. If it is not that, then we should give little time with some painkiller and good antibiotics, so that it is pointed on one place, so that aspiration would be little simple, maybe but I think it will take little time, but it will give a proper pointing where a incision can be taken. That's all.
Indeed. That is also
From
possible.
invasive to we have to go come little minimal invasive. This
Yes,
is
I think it
very
is
well. Even I was in a favor of incision and drainage because I have done so many in civil hospital, but I have now shifted to aspiration because the patient, we are giving a less invasive to the patient. One, second, she can continue to the breastfeeding.
Yes.
And yeah, it is comfortable for the patient, not for the doctor. In
Yes.
IND, we rupture that all loculi and we lose the breast tissue. There is a big fibrosis remains after healing of that whole access cavity. And here in aspiration, you just give the natural healing from inside, and it happens. So we all have to shift towards.
Yes, I think so. It is a good take-home message that the studies of today are, pointing more towards repeated needle aspirations. See, anyway, she has to come to the hospital for dressing. So then instead, she might as well just come to the hospital for the aspiration. Dr. Seema, what would you, what antibiotic would you want to give her?
Yeah, I usually go with amoxicillin clavulanic acid combinations. That will be my first choice. Second, in few cases, I also give azithromycin.
Yes. I think these Azi, I'm not sure. Erythromycin maybe would probably be what would be recommended. Yeah, erythromycin, cephalosporin.
It is for staph. Amoxicillin works better.
The discharge for culture sensitivity.
Yeah, so I think all of us must have found that although we send the discharge for culture sensitivity, very often we do not get any growth. Because probably we've already given adequate antibiotics, because usually they come first with a little bit of mastitis. We've already given antibiotics, and then then afterwards the abscess forms. So very often it is such that we do not get any kind of growth. But I think as a routine we do send it, and that is what is recommended by most studies also. So I think there's nothing wrong in sending it for culture sensitivity. And I think
cloxacillin is also good. Cloxacillin.
Yes.
Amox and clox, both combination is best. If you think of anaerobic, you can add metrogyl.
Correct.
Anaerobic is little rare in the breast.
Very rare.
Yeah. Dr. Anuradha, so what is more important? Prevention is any day better than cure. So we as obstetricians, have to join hands in preventing such kind of breast abscesses from forming. And what would be your take on this? I would probably want every panelist to, just give us one tip on good breastfeeding technique, which they follow in their hospital. So I think each one of us can answer this particular question.
there should be a good breastfeeding technique, but firstly we have to also, during the NCs, we have to take care of her nipple. If they are sore, if they are cracked, if they are retracted, and we have to give some time at 26 to 28 weeks of a gestation, particularly for the primary women, to counsel about the nipple care. If there is a nipple discharge, if the many of the primary patients have the crusting on the areola and nipple, so we have to advise them about the cleanliness and the little massage to a nipple, and using some lanolin if they have a very dry and a sore skin, especially in the winter. We face problems with the cracked nipple, so we have to counsel them for you using some lanolin application or any
I think so.
they can use
Antenatal talk about the breast and
Yes.
taking a look at the breast is, I think, because we are so busy in our OPDs, we just take a look at the tummy quickly, just fetal heart dekh liya, and the patient is out, the next patient is in. So probably taking a look at the breast is a good idea, and talking to her about breastfeeding, which is going to, it is quite like a new sport which she has to learn. We have to at least introduce her to the topic. Dr. Vandana, what would be your, good breastfeeding technique message just now? Dr. Vandana Gandhi?
She's not there.
She's not there.
She's left. Yeah.
Oh, okay.
The
So
breast,
I think,
the second point is latching, proper latching.
Proper latching.
Yes, it's extremely
That also early rooming.
Yes.
With the baby, as soon as after delivery, we should encourage them, the baby, to be with the mother.
Absolutely. In our country, that is not much of a problem. Early rooming does happen because it's in the West where the babies are in a cradle or in a creche or something. But in our country, it's not such a big problem. Dr. Rajendra, you would want to give your input?
Yeah, madam, patient should be propped up and baby should be vertical so that the gases or air, whatever is taken along with the milk comes out and the milk goes down. There is no vomiting post this, and the mother should be having loose, comfortable clothes to wear so that the baby can be easily and nicely fed.
Absolutely. So I think there are a number of breastfeeding positions that have been recommended. Even if the mother wants to lie down and breastfeed the baby, it is perfectly all right. You have a football technique, a baseball, and the cross cradle techniques, all these techniques. But what is important is that the infant's mouth, chin, and umbilicus.
Like it should be an airtight grip.
Yes.
And latching should include the nipple as well as areola in the mouth of the baby. It should be noiseless when the baby is suckling.
Absolutely well said. I think these are all very important take-home messages, and we have to let her know that the breastfeeding has to start immediately, and only then will the milk keep on coming out, getting secreted in a good manner. And Dr. Charmila, what would you have to say about prevention being better than cure for breast abscess?
We have to take out the time for counseling, because you've got two extreme group of patients nowadays. The one who wants to constantly feed 24 hours a day, and the other group which never wants to feed, saying that she's finding it difficult to have milk, and all of them assume that it's a reservoir there, and the moment the baby touches it, the milk will flow through. And we have to tell them it's not going to happen, and suppose a cesarean has been done, it will take 2 to 3 days for it to settle. So they have to, the counseling has to be very, very, very pakka for them on the first day of delivery, because most of the times they'll have information from us. Girija was saying the WhatsApp university would have given them so much of information. So give the correct information and tell them. I always use the example of a cow and a calf. Like the calf has to put its mouth to the breast before the milk comes. It's not going to come by just the milkman going and taking out the milk. So you have to tell them, put your baby to the breast first, and once then the neurological stimulus starts, and then the milk comes. And it's not a machine. It's not going to flow whenever she wants. So she has to take out that effort. And when you're very strict with her and a mother-in-law, it usually is good. Otherwise, this cracked nipple happens and they'll come back with an abscess after 10 days.
Absolutely. Dr. Seema, can we just have one input from you, that if she comes to you with, just engorged breast, just now we talked about abscess, but if her breasts are only engorged, then how will you help her out?
I would actually ask her to first, means the nipple and areolar portion, I will ask her to smoothen with her fingers, and then only give for suckling to the baby, so that it can then latch properly. If it is a hard breast, engorged breast, baby cannot grip, the baby's mouth grip is not possible, and baby won't be able to suckle. So first thing, and I will ask her like alternately she has to express the milk also. If she is feeding from us, means milk secretions are more, breasts are getting engorged, then she has to feed from one side, other side she has to express the milk. Next time she has to alter, feed from the other side, express from the other side.
So most important is you have to relieve her engorgement. So firstly, you have to reassure her that it is not a big problem. Don't worry, we are here to help you out. So reassurance, make her relax.
We are having
And you know,
pumps also.
you can use hot and cold fermentation. You can use cabbage leaves. And of course, you can use either manual methods or you can use a breast pump in order to engorgement. And you have to make sure that she's feeding, the point is just to empty one breast completely and then move the baby to the other side for feeding from the other breast also.
So
these
best
are a
solution is breastfeeding.
Sorry?
Easiest, breastfeeding.
Yes. So we have to make sure that we teach her a little bit more about the techniques of breastfeeding. So with that, we finish our first case, and I think Dr. Vandana is not here. So Dr. Anuradha, you would want to go ahead with this second case. This is a 28-year-old sexually active unmarried girl. She comes with complaints of a lump in her right breast. She says that it was there since the 10th class, but now it is somewhat bigger and it is occasionally painful. There is no family history of breast cancer. So how would you want to proceed in this particular case?
First is the clinical examination, madam. If the lump is firm, it is solid, it is mobile, skin on the lump is normal. There is no discharge from the nipple. Then it is supposed to be a benign, and the age is a good factor. So at the 28th year, it is more likely to be a benign tumor, and the malignancy is less likely at this age.
Absolutely. I think well said. So now when you examined her, you saw that it is a 2.5 to 3 centimeter mobile, solitary, non-tender lump in her right breast. Okay. Left breast is fine. There is no other problem anywhere else. So what diagnosis would you wish to come upon?
The most common at this stage is a fibroadenoma of a breast, which we see commonly.
You would like to highlight a little about fibroadenoma?
These fibroadenomas are the most common benign tumors which occurs at this age group, and they are usually solitary or multiple. They are benign they are usually benign,
Yeah. So what is important? What investigation would you like to do, Dr. Savan? You want to take over the question of investigation?
Yeah, madam. First, most important is local examination is very important. That we have to see the number and the size and mobility, and then second, then we can go on to looking at her. If we go for an ultrasound, that is the best thing. You can just see by that. But some patient we may think of doing mammography also. But to localize and see the
Yes. Now she's just 28-year-old, and on ultrasound you're going to get a beautiful picture, because we all know that ultrasound is the preferred modality for any kind of diagnosis of any breast lump, because the breasts are quite dense in the younger patient, and so ultrasound is going to be much more better than any mammo or anything for this young girl. And we are suspecting that it's most probably a fibroadenoma. So here you can see that fibroadenomas on ultrasound are usually seen as more transverse as compared to vertical height. I mean, they're more elongated, oblong kind of lesions they are, and they are a hypoechogenic uniform mass is what we usually see as far as on ultrasound. So now this young girl, you have told her that young lady, this is just a fibroadenoma, and it is also called as mouse in the breast. It is a very common kind of a tumor that we find. The ultrasound we have diagnosed. Now the point is that for any lump in the breast, friend, triple assessment algorithm is what we're going to keep on hearing again and again. You've clinically assessed that it seems like a mobile lump. You are, imaging modality, you've done the ultrasound, and you have diagnosed that it is fibroadenoma. So would you want to go in for a tissue diagnosis in this particular case? Dr. Varsha, you can highlight this.
Yeah, here I have to have a complete examination of this patient. I will feel the lump. One, I will see the mobility of the lump. Third, I have to examine the lymph nodes. If at all are there, I have to look in the view of malignancy. If I screen everything is normal, then I would not go for any tissue biopsy at present.
Correct, correct. Dr. Charmila, you would want to add anything about tissue biopsy in a young 28-year-old, 3 centimeter, almost surely proven fibroadenoma?
See, it can be either way. Hers is, she says it's growing. She found at the age of 15, but now at 28, she feels it's growing. It's got a painful element also there. So your ultrasound will pick up whether it is fibroadenosis with fibroadenoma, or it's going to be only a fibroadenoma. So you will have a suspicion of what you're going to see. When you have a suspicion, it's better if you do go for a tissue biopsy, because sometimes even in very young patients, because there's a change in symptoms, the lump is growing, and you can actually have a phylloids also sometimes, which are picked up little early also. So it depends on what your clinical finding is. So as Varsha said, your examination should be the focal point, and it will tell you whether you will go for a tissue biopsy or not. But probably for this patient, I will not do, because she's just saying it's a little growth, not a big increase in size. And that's the way, it depends. So I will not comment on whether
if somebody is terribly anxious and somebody is so worried all the while, if she's some HR somewhere, or if she has some strong family history of breast cancer, obviously we will be doing a biopsy. But otherwise, in our routine practice, we don't necessarily have to go in for a biopsy of this particular fibroadenoma. So Varsha, what would be the indication of surgery in this particular patient? If so, or for any fibroadenoma for that matter?
If it is, first thing is suspicious of any malignancy. If she has a family history, one thing. If it's, as Charmila said, if it is growing very rapidly or in a short period, if it is increasing in size. Second, the ultrasonography finding, I would like to see whether the vascularity of the lump, that is the mass. I have to see what kind of vascularity it has got.
Yeah, so usually the fibroadenomas are not vascular. They are very, very simple. What are the guidelines that have been mentioned currently is that if the size of the fibroadenoma is more than 5 centimeters, if it looks like a giant fibroadenoma or a phylloids kind of a tumor, it's a complex fibroadenoma. Fibroadenomas beyond the age of 35, or there's a family history of CA breast, and most importantly, patient request. So Dr. Chavan, now this patient has come to you and she tells you, Doc, I'm uncomfortable, I want to get this fibroadenoma out. So what will you do?
Actually, madam, when they come to me, quite a few girls, they come to me from the school or college. Then my simple this is I tell them to see रास्ते में काफी पत्थर पड़े रहते हैं, सबको निकालने की जरूरत नहीं रहती है. जो पत्थर रास्ते में गाड़ी अटकाती है, कोई तकलीफ देती है, तो उनको करने की जरूरत है. बाकी ये सब पत्थर तो ऐसे पड़े रहते हैं, इसके लिए चिंता मत करो, कुछ टाइम के बाद देखेंगे. If it is the smaller size, then we just tell her and counsel her that just go on, not worry. And these are there, you can see. So this is the first primary counseling which we do. Because in rural area where I practice, where most of them practice, there they have a guard bola, so they have this thing in mind that कुछ cancer problem. So they are really worried. But then we tell them they get counseling.
Okay, good to hear that. But Priya, now this would you try ormeloxifene with her? Has anybody in our panel tried ormeloxifene for fibroadenomas?
No, madam. No experience.
No.
Charmila, I have tried ormeloxifene for this also, and it works. But if there's small multiple, then they shrink to some extent at least. But of course, the question again arises: how long will you keep giving them? But if they're very young, say they're barely 18, 19, and they have multiple small fibroadenomas, then I have given for these cases, and then for a few months they regress, and the patient is also quite. She accepts it as she grows a little older. And we've had a decent experience with ormeloxifene.
For this patient, there's an indication for giving ormeloxifene. She's complaining of pain. That's the reason she's come to you. So there will be a fibro, and this is a hormone-dependent tumor. Yes. Give ormeloxifene for a period of time. She's got a symptom relief. Everything is clear. Then you can follow her.
Absolutely, absolutely. But now, Dr. Seema, she says, "No, doc, nothing doing. I want this out." So will you remove this fibroadenoma?
So if she wants and she's not listening, we have to remove it then, and we'll remove it. We'll take a circumferential, like just the areola, inside the areola, we'll take the incision and remove it.
You will do it, or you'll call a surgeon?
I do it.
Very good.
Yes.
That is the most important thing. I'm happy and proud of you, Seema, because it's extremely important. We have to take the breast back. It's our organ. It's a secondary reproductive organ, and it is so simple. We remove such large fibroids from the uterus, and why we cannot remove this small fibroid?
Fibroadenoma is the easiest thing we can remove.
It's so easy. It is so easy. 10-minute procedure. Quickly take a small incision. Just enucleate it. Hold it with Alice. Pull it. You may use a little bit of cautery at the base. Confirm hemostasis and give her a beautiful monocryl, suture.
Particular we can take with monocryl
If the fibroadenoma is superficial, you are easy to do. It is a mouse in the breast. So mind well, you need to have some assistance before doing it. One.
Yes,
Second,
that is very important. We cannot disappear the girl. We cannot
years back, surgery society has already given this organ to you, so you can deal with it.
Yes, but if it's very deep and if it's very big brain space, sorry,
I've not needed surgery yet to remove it.
Won't do. Good job, good job. So as Varsha rightly said, if it is very deep, it's a very big breast. It's not too big a fibroadenoma. You may unnecessarily dig here and there. It's better than you may want a surgeon only in certain situations. Fantastic. So this is special mention on cystosarcoma, phylloids, large painless non-epithelial tumors. We had one of these cases in our OPD only. This is a web picture of these large cystosarcoma phylloids. But nowadays they are just called as phylloids because most of the times they have been found to be benign. Treatment is lumpectomy with tumor-free margins. But if it is very, very large, you may have to go in for a mastectomy. So we move ahead to Dr. Rajendra for our next case. Divya has already talked a lot about this, but we would just want to revise clinically what you want to do or what we do in our clinical setting. We have this 35-year-old woman who comes with pain in both the breasts. And she feels there are lumps in her breast which typically increase before menses. And currently she's premenstrual, she's irritated and she's come to you. So Dr. Rajendra, over to you.
Yeah, we'll have to investigate it. Just see. Local examination we'll have to do.
I think your internet is a little unstable because we are unable to hear you clearly.
And we'll have to rule out any tumor or any mass or anything. If it is not there, then it may be hormonal problem that she might have come. So this is what we'll have to do her investigate her.
Dr. Varsha, you want to add something?
Yeah, this is a classical case of fibroadenosis.
Yes.
She has this pain premenstrual. So first of all,
somebody's mobile, two instruments are working, two devices.
I know. So in this case, her pain is the problem. So give her simple analgesics.
Varsha, now she's 35 years of age. And she's pain and you can feel little nodularity.
I have to go ahead with doing a sonography for her.
I think so. I would want to
as a mammography once at least to know whether she has any infiltrative kind of disease. You have to look for this infiltrative. If it doesn't give you any lump, she only has a big breast and she has that suspicious mind. So think of this, that in spite of pain, you have to go ahead doing sonography as well as mammography once.
Yeah. So how many of us do sonography of the breast on our own?
No, ma'am. We get it done.
So actually now, if you have your own sonography machines, start just handling that small probe, that a probe which is for the breast ultrasound. Just start keeping the probe on the breast, just as we are teaching our patients to be breast aware. Now we gynecologists have to start becoming ultrasound aware of the picture of the breast. Okay. So the cyst, though, you can diagnose in a minute. Okay. You can definitely see beautiful cyst. Fibroadenoma is also very simple, okay? And maybe fibrocystic disease is little difficult to diagnose otherwise. But if you have a proper cyst, it's very beautiful. So what is the whole bottom line of our breast committee is to train the trainers, train our gynecologists now to become even more breast friendly with palpation, with clinical examination, and with our ultrasound. All of us have an ultrasound machine. All of us have that small probe, okay, which is used for breast, thyroid, and things like that. So please just keep it. आपल्याला काही कळो न कळो, either you understand something, you don't understand, you keep keeping it, and one day we will start learning. Because just as we've learned so many things, we've learned our own follicle monitoring, we've learned our own early ultrasound scans, and maybe those who are into obstetrics in midway are doing their obstetrics sonography. So similarly, we can do our own sonographies for the breast. At least start diagnosing. You send later on outside, that's fine. But at least you can relax your clinically, and even on my ultrasound findings, I cannot find anything abnormal. So as far as fibrocystic, sorry, somebody was saying something.
I was saying that it's a matter of all PCP and DTC. Nobody touches this.
But breast is there. Breast is okay. No, you don't have to. Yeah, you don't have to enter anything. No forms to be filled. So many often that is a painful lumpy breast, swelling, thickening of the breast can be seen, and very often they can have greenish yellow nipple discharge also. And these are all very typical of fibrocystic disease or fibroadenosis. Now, it is not associated with an increased risk of malignancy. Very important take-home message. But certain histopathological types could have a 50% chance of developing breast cancer. So it is a good idea to keep following up these patients. So Dr. Anuradha, how would you manage these patients of fibrocystic disease? Dr. Divya has
Firstly,
yeah, you can just
yes, madam has given a wonderful talk. First is a good counseling that we have. There is a very less chance of having a malignancy. Secondly, the patient has to have a restricted caffeine intake.
Yes.
Then there is a role of an NSAIDs. Then tightly fitting bras. Then OCPs, progestogens, danazole, evening primrose oil, and some we are using as a first line to give. We are using also pyricontin and all, belong F and all. Surgical excision we have not done up till now. Patient will respond very well with all these remedies.
Absolutely. So lifestyle change is very important. What do you say, Charmila?
Diet.
Yes, very important. Dr. Charmila.
Yes, diet.
Dr. Charmila is here or she has left?
Yes, she is talking.
Oh, I cannot hear, madam.
I think she has left.
Okay.
All right. So I think this lifestyle change is extremely important. Good diet, good exercise, well-fitting bra, sometimes hot and cold fomentation. These things are very important, and they usually go a long way in taking care. NSAIDs, even local creams are effective. I think that is important to remember that local gels, pain relief gels, like Overrun gels can also help to reduce the pain. And we've talked about ormeloxifene, indeed a wonder drug. Danazole, tamoxifen are advanced drugs. Most of the times we do not need to take these. Okay. Now, Dr. Anuradha, we have this next case. So who's come to you? 42-year-old lady who comes to your clinic and she wishes to know more about breast wellness. She's heard that breast cancer is increasing in India and she wants to take care of her breast properly. She's otherwise totally asymptomatic, no problem with her breast, and she's into preventive health. Weight is 58 kg, BMI is 24, no hypertension, no diabetes, regular exercise, working part-time, breastfed babies, no family history of any breast cancer. Now what will we do?
Yes, we have to teach the patient about the self breast care examination. Then we have to teach our all patients. Then we have to get it done by the gynecologist.
Dr. Anuradha, this is a very, very important topic of self breast examination. I would want you to just speak a few highlights about self breast examination.
So the examination has to be done in a relaxed position, that the arms to be kept on the it should be kept, breast should be on the relaxed position. Then they should palpate with the palm, and not fingering has not to be done, and it should be done on the usually on the first half of the menstrual cycle, because afterwards sometimes they may feel some lumpiness. So those patients who have a fibrocystic disease, they may feel some lumpiness in the breast and they may feel some pain.
So that is very well said, that it has to be done once a month Immediately after the periods, if the woman is not menstruating, she can fix any day of the month and do her self-breast examination on that day. With the middle portion of the fingers, feel for the marble in the bag of rice. Do not forget the tail of the breast, which is in the axilla, and look for nipple discharge. Now, what is most important is that many studies have said that there is insufficient evidence that breast self-examination is effective in reducing mortality from breast cancer. But what is important to remember that in a country like India, where regular mammography and regular physical examination of the breast are not practicable because of public health policies, breast self-examination is very, very, very important. And in a country like India, we have to make our women breast aware. Our women don't even talk about the breast, leave alone touch the breast. So what is important is that we make the women breast aware, let them even feel how their breast feels. And only then they can diagnose a lump in that particular breast.
If she has come to you for the advice, don't leave her, examine her, get a mammography.
Correct. So now you have taught her about self-breast examination. And now, Dr. Seema, you are going to move on to clinically examining her breasts. How do you do it?
So we can examine her more preferably. I would prefer in lying down position, both her arms over her head, and with my flat hand, with the middle of my fingers, with flat hand. I'll be just in rotatory movements. I'll be feeling whole of the breast tissue as well as the axillary portion. And if there is no lump felt, then I would tell her that it's normal. But I would suggest her for because she's more than 40 years to go for a mammography. Just
axilla in sitting position.
Wonderful. Okay, so there are 3 positions in which you want to examine her: in the sitting, with her hands raised up, and with her hands on the chest, and of course in the lying down position. Obviously, we don't have so much time, but a good lying down position checkup is good. There's a radial approach, concentric circles, or vertical strips. What you to remember is you to palpate right up to the clavicle, up to the lower edge of the breast border, up to the middle of the sternum, and laterally up to the axilla. Extremely important. So now you examined her, you have not found anything wrong. Okay. And of course, the clinical breast examination, all the studies are saying that there's a significant decrease in breast cancer mortality because of clinical breast examination. It has been proven beyond doubt. So Varsha, now we move ahead to who want to suggest her a mammography. So what will you tell her? She says, no, doctor, it is very painful. I don't want to do all that.
Yeah.
And now you've checked me. She says, Ata tumhe bagitla na Varsha madam. You've checked me, there's no problem. Now let me go. Why are you making me do mammography?
So I have to counsel her first. What is the modality of treatment? How is it? Mammography, how it is done? So I have to counsel her before. She has to mentally prepare for that. Okay. And then I will ask her to get it done because I have to tell her the significance and what's sensitivity and specificity of the
So what all the studies all over the world are telling us that mammography is the gold standard to detect early stage breast cancer before the lesions become clinically palpable. So you have to tell her that what my hand cannot feel, my mammography machine is going to tell me. So whether she's high, every woman, just because she's a woman and has a breast, is high risk for breast cancer. As many as 1 in 6 urban women are going to develop breast cancer. So it is very important to convince her that mammography is a must. So we have the BI-RADS staging, we have the reports which are being mentioned. We probably deal that at some other time. But this is a very important take-home message that the screening mammograms have to begin between the age of 40 to 44 years. But in our country, they can begin a little later also, beyond 45. But I think it's wrong to say that because in India, we get breast cancer at a much earlier age. So ideally, even at 40, if you begin a mammography screening, it's a good idea. Annual screening is very important. And beyond the age of 55 years, you can do a mammogram every 2 years. Okay, so this is very important guidelines for mammography. Dr. Rajendra, do you think that we should use ultrasound? Why can we not use ultrasound as a screening tool? Just come to you, you have ultrasound machine, you have somebody coming to do sonographies. Says, doctor, don't send me. Why you want to send me for mammo? Just do my sonography and let's finish it off. What will you suggest? You don't have to follow what I've written. You can tell me what you feel. I think you are muted, sir.
I would advise that mammography is the proper thing. Ultrasound will give limited knowledge, and X-ray along with that will give detailed knowledge about the Virat's grading.
Correct. So it has been seen that, see, but what I personally feel, if there is no mammography in your area nearby, then at least do an ultrasound. That is all what I would want to say. If there is no mammo and she's very fussy patient, at least do sono. And if you find something suspicious, then okay, you could go ahead, definitely. But undoubtedly, mammo is the gold standard. But and it has been seen that ultrasound screening in asymptomatic women causes unacceptable false positive and false negative outcomes, and it is not acceptable for breast cancer screening. This is an important take-home message. Other screening methods like MRI for high-risk patients, genetic screening, the BRCA testing. I think we all have to realize that all these facilities are now available in all big cities. We have to suggest, Dr. Anuradha, you want to say something on this particular point? All right. So this was about a 42-year-old woman who had come to you for breast advice. You told her about self-breast examination, clinically examined her, and advised her mammography. Okay. So these are our guidelines, doctors, which tell us that once the woman girl is 20 years and above, self-breast examination should be done. Clinical examination may be optional. Self-breast examination is monthly. She's 40 plus, mammography is compulsory annually. High risk, mammography plus MRI annually. That is very important. So
Madam, do you have any idea about thermal digital thermopics?
Yes, thermography. I don't think I've included it over here, but now you have the non-touch modality called thermography, which is available. It detects the heat produced by that particular organ. We know that a lump, if it's malignant, it is a rapidly multiplying cells they produce more heat. Am I right?
Yeah.
That is why, because
they take the X-ray of the heat.
Yes.
And then
machines are coming very much into vogue, and I just underwent my own thermography in Jaipur, and they gave me a clean sheet. But what is important to remember is that these things are available. Maybe once we are all well versed with the basics, we will talk more about these advanced methods of a diagnosis of breast cancer.
But the thing is, one of the organization, they want to introduce that in my area, and they want to give it that 30 lakhs.
So you please take a trial, Dr. Chavan. Please take a trial, because the breasts have to be cooled. The breasts have to be cooled for 10 minutes with a good fan blower.
Right.
Now, once the breasts are cooled, then it's very simple non-touch technique. And see, previously it was the man behind the machine was important, because they used to read the report manually. But there were people, the breast consultants or somebody who was well versed with the thermography machine had to read it personally. But today there is artificial intelligence who's doing it. Now, because artificial intelligence is involved, now all our pap smears soon will be read by artificial intelligence. All our MRIs will be read by artificial intelligence. Very soon all these things are going to happen. But because of the artificial intelligence, I think it's a good idea, because it is very simple. There is no pressing on the breast. There is no radiation involved. So it's a good method.
Almost 99% sensitive.
It is a good method, doctor. Please start it. And you, in the next webinar, you're going to tell us about the outcome of that particular.
Yeah, definitely.
Madam, just a query.
Yes.
If she is 40 to 42, thin build, on self-examination, there is no mass.
Yeah.
Examination by doctor, if there is no mass, still we have to suggest mammography every year for that patient.
See, this is a very good question. In India, we have to modify things. Okay. In India also, they say every 2 yearly also you do, it is okay. Okay. But what we have to remember is at least she has to come for clinical breast examination. And it has been proven beyond doubt that with mammography, you can diagnose lumps which are not palpable to the hand. Now, just I will go back one slide, and I will tell you that here you have to understand that along with the Biorite classification, there is one more, reporting system of which radiologists follow. Believe me, the women with these kind of dense breasts, these are the ones who are at high risk of developing breast cancer. If she has microcalcifications, she's high risk of developing breast cancer. So woman with dense breast, woman with a non-dense breast is extremely important to remember. And you have to identify who are high risk, and then you have to suggest for these. Very tiny breasts, very thin woman, they are not high risk for breast cancer. You can do away with it. But I think you have to identify high-risk breasts on mammography. We will learn about reading the mammograms next time. But you have to identify them and do for them specifically every year. Just now, I have a friend who is 52-year-old, very dense breast, lots of microcalcification. Every year she does her mammo. Only COVID she didn't do 1 year. And this mammography has got a tiny lump. She has undergone lumpectomy, oncoplasty, and now she's undergoing chemotherapy. So you can save the life and you can save the breast also. That is the take-home message, actually. So it is very necessary to identify high risk. So I think we just move quickly to this last case because our one more talk is left. And Dr. Priya, I think you can take this question. 52-year-old menopausal since 1 year complains of lump in the breast. She felt it a month ago, but she was traveling. It is painless with a slight increase in size. What further history would you like to ask? And how will you go about it?
In her menstrual history is important. Early menarche, late menopause, maybe the risk factor. Then family history. If there is a disease in the family, then breastfeeding. How many months she has breastfed her babies? Breastfeeded her not. If she's on any medication, and then if there is any lump anywhere else other than breast in the axilla, if there's any discharge from the nipple.
Correct.
This history is very important for this patient who is 52 years old.
She's just very simple 52-year-old. She breastfed her babies. She had her menarche at say 13 years of age and menopause at 51 years of age, and not very obese, nothing very significant. So just remember the non-modifiable and the modifiable risks of breast cancer. As you rightly pointed out, a family history, early menarche, late menopause, increased breast density. Friends, please don't forget this point. It's very important risk factor for breast cancer. So now we will just talk about what are the, now you started examining her. Yeah. And what all will you look for? She's 52-year-old, she has a lump. The first thing we think of is obviously CA breast. So what all will we look for?
First, when we examine, we see for the lump, we feel for the lump. It is usually hard. It is with restricted mobility.
Correct.
Usually it is attached to the skin overlying skin. The nipples are sometimes pulled in. There is dimpling seen in the nipples many times. There could be some discharge in few cases, and even in few cases redness might be seen, and the skin over that region is usually changed a bit.
Absolutely.
So main thing is the hardness of its consistency, like consistency, mobility. These two are the main major things which differentiate them from the benign lump.
So a lump which is irregular with restricted mobility, changes in the nipple, any kind of discharge, and changes in the skin. It's usually a very, very rare symptom, although it can be seen in 10% of cases of breast cancer. Okay? So now you started examining her, okay? And you found a lump over there, okay? So now what will you do next? You have a clinically, this is, suppose, this is the algorithm for examination. Now you are finding a suspicious lump. Any of you can answer.
This should be biopsied, madam. FNAC is to be done. We have to confirm whether it's a malignancy because she's a 52-year-old and the age is a very, very important factor.
But we'll do mammography also for her just to see.
So what will you do first? What will you do first? Anybody from the panel? What will you do?
Yeah, we have to go ahead with mammography.
Mammography first.
And this,
always remember that the radiological investigation has to happen first, and only then of a biopsy. Why is that so? Because your biopsy can sometimes cause edema, inflammation there, and it can distort the mammography image, and that is why mammography is compulsory before doing this. Okay, you did a mammography, and you of course you saw that there are no nodes. So triple assessment algorithm, friends, always remember clinical examination, radiological investigation, and the biopsy. Now, somebody mentioned that we have to go for FNAC. Friend, very important to remember that rather than an FNAC, now it is the true cut biopsy which needs to be done. Okay. I forgot to put a video. The next time I'll be putting a video also. We have started doing true cut biopsy. Extremely simple. Okay. Very easy to do because sometimes FNAC can miss, especially if it's a small lump, it can be missed. The true cut biopsy can be done under ultrasound guidance also. And sometimes you can have an excisional biopsy. That means it's a very tiny lump. You're not sure what it is. Remove the whole bit and send it for histopathology. So very often nowadays, friends, it has been seen that we do not do only mammography. We always combine it with ultrasound because ultrasound has its own positive findings and mammography has its own positive findings. So very, very important that in any major center today, you will have mammography and sonography being done simultaneously for that particular patient. And the patient might come and ask you, okay, why they did like this? You have to be able to tell them. So now, I think that because our discussion is going ahead and now if we diagnose breast cancer, we are going to send the patient to either an oncosurgeon or a breast cancer consultant. We will be discussing, there's a lot to discuss in breast, but we will, due to shortage of time, we will be winding up our panel. There are different types of breast cancers. And what is important, friends, once again over here is the multidisciplinary approach. Okay. Please remember to involve counselors, medical oncologists, family physician, gynecologists, oncosurgeons. Everybody has to be here. And nowadays, very important is the fertility specialist also. Because in our country, we are having breast cancer at a very younger age. You know, she may be barely 32. She may not be having a baby also. In such cases, you have to make sure that you send her to a fertility specialist. The fertility specialist, she has a steady partner or she's married, she can preserve her embryos. So you can start I think Seema Patil, all of you all are fertility consultants. So, you can start her on a cycle to stimulate her, retrieve her eggs, do your, ICSI and freeze her embryo. Okay? Give her the option of preserving her fertility before choosing for any kind of radiation, any kind of oncological treatment. And of course, early diagnosis is going to not only save lives, it is going to save the breast as well because we can now do only lumpectomy or quadratectomy and use oncoplasty to save the breast. So, oncoplasty is very, very important. Early diagnosis can save the breast also. So as we come to the end of our panel, I would want to say that prevention is better than cure. Managing the patient's weight, her diet, physical activity, breastfeeding her babies is probably the only thing that we can suggest to our patient. We are her point of first contact. So breast is a secondary reproductive organ and every gynecologist should be very well versed with it. Most lumps in the breast are not malignant, but every lump in the breast has to be treated as malignant unless proved otherwise. The triple assessment algorithm helps to streamline the management of all breast lumps. Ultrasound and mammography are complementary to each other, and a multidisciplinary approach in the management of breast cancer is a must. Thank you, dear panelists. You have been an excellent panel, and I would really thank you for your active interaction. And we will keep many more, and we'll be keeping discussing many more advances in this field of breast cancer management.
Thanks for a wonderful panel, madam. You are excellent as a moderator. We just loved it.
Oh, thank you, Anuradha. Thank you so much.
And all the best for your breast committee.
Absolutely. Thank you, Varsha. You are going to be a close friend and confidant, and we all have to take this ahead. And I'm sure that today's delegates, today's panelists, everybody hopefully have benefited from this particular panel, and we will take the organ of the breast back. And now I will stop sharing, and we have a very important talk. Please don't leave because Dr. Shaila is going to talk about how to organize a breast cancer screening camp, and it is very important to all of us because all of us need to do this on a much larger scale and spread the message of breast awareness. So over to you, Dr. Taru.
Thank you, Dr. Charu. Very nice panel. All the chapters concerning this breast are covered in this panel.
Thank you.
So,
thank you.
Early detection will improve outcomes.
Correct.
Breast screening is the medical screening of asymptomatic women in attempt to achieve early diagnosis. How we promote and organize. Now we have discussion on this. Our esteemed chairpersons are Dr. Siyoga
Panat.
PANAT, Panat. She is consultant OBG Society at Amravati. Received late Srimati Saria Chaudhary Award and late Tripti
Ma'am,
we can skip this.
Yeah. She's a fantastic.
Yeah, these are very good awards you had.
Very intelligent, and it's a pleasure to have Suyoga over here.
He is a member of PCPND Advisory Committee Amravati at present also. And another speaker, chairperson is Dr. Nirupama. She's President Kolhapur OBGY Society. And MRCOG, she is very nice and working with NGO Jan Swasth Daksha Samiti. This is very important because we are just going to have this only, how we can organize our camps and how do we do according to this. Please, Dr. Siyoga, can you please introduce?
Yes. At the outset, I would like to extend my thanks to respected Charu Madam and dear Dr. Monica for giving me this opportunity to chair this wonderful session. And after the brainstorming panel discussion, we are here with another important session, and we have with us a very active, dynamic social activist as well as a medical journalist and writer, Dr. Sehla Jamal, and I am indeed privileged to introduce her. She is associate professor at RMRI Raebareli. She is founder president of Menstrual Disorders and Hygiene Management, chief editor, Journal of Reproductive and Menstrual Sciences, director Menstrual Health Sciences at Pinkshi Foundation. She is a North Zone in charge, Young Talent Promotion Committee, FOXY. She is a coordinator of Endocrinology Committee, FOXY, and MEU coordinator. She has 44 publications in national and international journals. She has contributed 7 chapters in FOXY Focus and other books also. She is a peer reviewer in 4 international journals. She has many awards to her credit. She has got the FOXY Leaders of Tomorrow, FOXY PAC Award, Award of Honor by WHO. She has also received Award of Excellence by Gram Laya and Ministry of Sanitation and Drinking Water. She has achieved first prize in paper presentation in Adolescent International Conference. She has also received the Corona Warrior Award by UPCOG. She has presented papers, lectures in many international and national conferences, and she has also organized many state and regional conferences. So over to you, Snehal Madam, and thank you again, Charu Madam. I appreciate your ever smiling nature, and really the panel was wonderful.
Thank you, Suyoga. Thank you.
Thank you, Dr. Suyoga, for your kind words, and thank you, Charu ma'am, for giving me this opportunity. I was still engrossed in your panel discussion. I was noting down the points. All were so practical and wonderfully explained too. So I hope my screen is visible.
Yes,
ma'am. Okay. So thank you, Charu ma'am, for giving me this particular topic, so different yet so important. So I'll be discussing how do I organize camps, and when I have written I, it means all of us as fraternity, how do we organize camps, right? So thanks foremost to the leadership of FOXY, and especially to Sneha ma'am, who introduced me to the world of breast diseases, the problems that females are facing. And thank you so much, Charu ma'am, for letting me continue in her endeavors too. So what is the need and utility of these camps? So need is we are connecting. We are connecting through these camps between 2 needy groups. If we feel that camp attendees are the only ones who need them, we are highly, highly wrong and misguided in our perceptions. We also need them. We also need to improve their health conditions and need to be there for them for their diseases for getting them screened earlier, to need to talk to them. And when we talk of utility, it has to be looked, because, a poorly organized activity actually is serving no one. As far as the definition of a medical camp goes, it means a temporarily organized activity within a specified locality in order to provide free, subsidized or sponsored medical consultation, diagnostic services or treatment. So one point I would like to highlight over here is that a medical camp need not always be free. We can always introduce subsidized or sponsored items, materials, and services into the camp to improve utility. So I will be throwing on insights on how to organize camps, because since last 13 years, I have been putting up, I think I have put up more than 94 camps in and around Delhi, NCR, different states of India. So I have covered almost 14 states across the country, and I feel quite privileged to do so. And more so because my husband is in army, so he has been taking me through and through the tour of this nation, and I feel very humbled and honored to serve womankind in whatever capacity I can. So it is the need of our, and as we all are with Modi ji, we need har ghar detection. Detection should be there in har ghar, and we should do it by ghar ghar jakar detection. So that is why the need of these camps. One word about the leadership of Dr. Charulata, who is chairperson of the Study on Female Breast Committee of FOXI. Without initiatives, leaders are simply workers in leadership positions. She has come out of that. She has put on this initiative as to how we can maximally utilize this activity, which is just seen as ek camp lagaya tha, ek camp kiya tha, ho gaya, photo khichwai aur aa gaye. So role is, these camps act as catalysts for women to seek medical attention or discuss with local healthcare workers concerns of discovering new lumps or developing breast symptoms, which they're unable to do so. They have no access. And as I always say, internet is for disseminating knowledge, which is not required everywhere, which is not required by everyone. So first and foremost, before we plan up a camp, we have to see what are the big intentions and what are the ulterior motives. So we are living in the era of 50 shades of gray. So not all our intentions can be absolutely wide. We are not doing it for pure social and humanitarian services. And if once, twice, thrice we are doing it, okay, good. But for others, even for the purpose of advertisements, even for gaining the number of patients, buyer-seller relationships or awards, it is fine. It is completely fine. We have to understand that whatever purpose we are doing with that, ultimately that female is the beneficiary. Ultimately, her breast is getting examined. Ultimately, she is getting some access to some diagnostic services, and she is getting access to a health care provider like yourself. So outcome can yield you photographs for social media, good. Numbers for records or awards, very good. But the ultimate thing is effect and impact. So let us understand the difference between effect and impact. I would like to use this picture. This is effect. The herd is gathered, large numbers, beautiful people, but this is impact. So this is what we are aiming for. Effect meaning result, okay? But impact means result with a blow and bang, or to pack firmly together so that we make a difference in that woman's life, right? So once we have made a difference by talking to her, by making her aware of her breast, her body, leading her, guiding her to healthcare providers, facilities, we definitely are doing this neki. Earlier it was said that neki kar darya mein dal. Abhi darya nahi hai, sook gaye. So neki karo and social media pe dalo, so that other people are also knowing that this can be done in this wonderful way and people can benefit from such activities. Along with this, collection of data is very important. So collect this data, use it for yourself, use it for your friends, use it for reflections, and use it for improvising. Now coming to when you are organizing this camp, your intentions are clear, you know what you want to achieve. Let us see what types of camps you can organize. They can be rural. Now in rural areas, majority of the camps are organized by politically inclined people. So you catch hold of them. The one who has won some election, take his help. He would want to win another election and help you. The one who has lost election, take his help. He would like to win another election. He will help you. Ask sarpanches, ask social workers, ashas, NGOs, NPOs. They have targets to fulfill. You help them fulfilling their target and your job is done. In urban areas, schools, colleges, corporates, lots of social responsible activities are going on. Take help from NGOs and NPOs and local individuals who more or less are working purely for philanthropic reasons. And for marginalized communities like commercial sex workers, tribal areas, these are, things and dreams of near future. But let's cover the majority first, then we can definitely come to them. So at the organizers' end, this is the picture. We are standing here, lot to see. So what is the first thing that we see? So now this gentleman in one of his very famous interviews once said that to be a philosopher or philanthropist, you need money. You need to be rich first. So we need not be very rich by money, but by heart, we definitely are. And we all know that nothing comes or goes free. So for health camp, take monetary help, sponsorship help from NGOs and NPOs, from farmers, from politicians, take some funded projects, because CSR activities of giants are going through. They have to spend 2% of their annual net profits on corporate social responsibilities activities. Government aided funded activities can be obtained through by registering NGOs or organizations in NGO Darpan. There we can get a lot of funds if we are eligible. And nowadays CSR linking agencies are putting up CSR meets and summits. There we can attend and we can find whom we can connect with. So as I said earlier also, because our intentions are very, very pure, but we need money. So these things can help us procuring that kind of money. There is a lot of money floating around. In 2021, 25,714 crores was spent and around 60% was given for healthcare by CSR activities in India. WHO, UNICEF are doing a lot of fundraising activities and they're especially utilizing them for health and education sector. Go and grab it. So we can always put up alliances. We can always ask our friends who have already, made liaisons with these organizations and done these activities to take help. So as we are the almost breast cancer capital of the globe, we need money. And here is the guide: CSR summits, activities, and liaising. So this is the number, I even can't read it. This is number of females with some sort of breast problem, be it cancer, lump, mastalgia, discharge, anything. So this number is scary. This is the number of females having breast problem across the globe at one point of time. In India, we are having 66.2 crores of females who are registering 1,16,000 cases of breast cancers annually, and one breast cancer case is diagnosed every 4 minutes. I have been given 12 minutes. While I finish, 3 cases must have been already identified. So we have to detect them. Mass detection camps are good activities. They serve as first point of awareness. Majority of the females must not be knowing only. Second is they will come to know about healthcare facilities, because during my entire experience, people do tell me कि हमें पता ही नहीं था कि यहाँ पे ये वाला hospital है और आप इस चीज को भी देख सकते हैं. And then finally, we can identify healthcare leaders who become points of contacts for further facilitating the dispersal of information, education, and diagnostic and treatment services for these females. So let's review some concepts. How to organize camps by way of site, size, season, sentiments, substance, and solutions. So site should be accessible, advertised, seating arrangements should be nice, there should be clean toilets, refreshments can be provided, but it should be hygienic, a private place, and infographics. Lots and lots of them should be displayed wherever you are putting up your camp. So the best of such a kind of site is a school. Schools are always well advertised. Everybody knows them. They are on Google Map. वो कहीं गलियों में और कोनों में नहीं होते. They're accessible. Rickshaws can go. Autos can go. So choose schools majoritarily while you're putting up camps. Second is Identify a female-dominated working place. If you are putting up for some company or anything, put them up near residential areas. दाना वहीं डालिए जहां पर चिड़िया उसको खाने आए. So there is no point wasting time at a place jahan pe majority's workplace is gathered by male working force. When we talk of size, organizers and beneficiaries should be proportional. Enough doctors, paramedics, counselors, and educators should be there. Take help of volunteers. They just need your certificate. Or kuch nahi chahiye. They will help you immensely in advertisement, in helping, in counseling, and in data collection and entry. So 20 beneficiaries per healthcare provider is the most ideal number. If you expect more numbers, take more doctors. Third is season. It is very important. It should be extremely comfortable for a woman to commute and unclothe herself. If you're using mammogram, if you're using your cold hands to do a clinical breast examination, she should be comfortable. Hospital-based camps can be organized in any season, of course, but when you are going for mass detection camps, you have to look for this Mausam. So the most beautiful Mausam for putting up camps is from 15th February to 30th April, and so September, October, November, entire 3 months can be dedicated for putting up camps. Then coming to sentiment. We have to look for what people might be, easily. आपने कोई ऐसा word use कर दिया उस pamphlet पे जो वहाँ के local population को offend कर जाए. We have to take care. We have to consult local bodies, local people, Lion Club, Rotary, DPOs. They are doing a lot of work, so they can easily tell us. Second is avoid festival times and examination times. Take proper consents, because if you have detected something, you want to take picture, even for social media, people may come and, put a backlash that why did you use my picture? So take proper consents. Advertisement, infographics should be in local language. It should be pre and post advertised in local newspapers. Awards and felicitation ceremony can be organized. Like if you give an award to an Asha, she will come and she will bring 4 or more people with her. And promote local people. Instead of promoting ourselves, we should be promoting local people, because they feel very great and grand when we are promoting them. And you are promoting them indirectly, you are promoting yourself only. Then proper substance, that is logistics, gloves, writing papers, info brochures should always be there. Pre-printed follow-up advice that you have to come after 7 days, just put up a tick, it reduces a lot of time. Pre-designed breast diagrams, just 2 circles, quadrants, nipple area, and tail of Spencer's that can be already be there, and you just have to put up the findings over there. Mammography device should be present in a very private area, not in khullam khulla. Thermal scans, handheld devices, if we are using, we have to put up proper screens. Cytology collection, if you wish to collect nipple discharge for cytology, whatever way, it has to be properly there. We just cannot carry away those cytology slides because it will serve no purpose then. Better not to prescribe any medications, because then what people do, they believe that if we will take medicine, we'll get all right. They will not follow your follow-up advice. Then you can organize a competition beforehand for posters, and you can put up those posters in that area and felicitate and give award to those people who have participated in those competitions. And finally, solutions. Solution comes when you know what is the magnitude of problem. So data collection is entirely and extremely important. You can do study and research, and it is not can do, you should do study and research. Breast committee can have a pre-designed pro forma, and we have, and I'll share it with Charu ma'am very soon. We will be having questions in that. You can add yours. Whatever you add or delete, just collect it at a central data pool so that we can analyze it, publish it, and use it for our future references. Definitive management can be provided on phone or email, and hospital appointment as per the patient's choice. Suppose I have gone 15 kilometers away. So I cannot call patient ki tum 15 kilometer dur chal ke aao. No, provide a healthcare provider who sits by her end, near her place. Extra miles to cross, even if you want it for your business plans, marketing plans, project proposal, campaigns, etc., go ahead. Because whatever you are doing, you are detecting breast cancer in females, which is ultimate goal. Extra efforts for making long-term follow-up arrangements, creating mascots and brand ambassadors, and licensing for repeat camps. This you have to decide then and there only. बाद में कर लेंगे नहीं चलेगा. If you have to put up a second date, put it up there, start planning from there only. And finally, do a SWOT analysis of your camp, identify your strengths, weaknesses, opportunities, treatments, and document them. Because the screening is not our endpoint. Rather, after screening, what is the kind of treatment, what is the kind of plan, what is the type of game we are going to play is our final endpoint. So let it pass through the funnel of awareness, discovery of more patients, evaluation of those patients, our intent to treat. In terms of locality, our thought process should be aligned, and loyalty to serve our patients and our nation. And final outcome should be the treatment of these patients rather than just the screening. So you have to plan them, keep your planners ready, and we will be having a bank with Breast Committee FOXY by putting up a lot of camps, lot of research, lot of data, and lot of good work. Thank you so much.
If I could stand up and give you a standing ovation, Shehla, I would have done one.
Thank you, ma'am.
Yoga, over to you. You have to unmute.
Extremely wonderful talk, excellent talk, and really we would like to give a standing ovation to Madam. And very rightly said that screening is not the end point, because after screening we need to treat the patient also and to take the regular follow-up till the treatment is complete. So hats off to you, Madam, and the slides were really wonderful. They were so meaningful. I would, if we can get this presentation, I would be very happy to.
Anytime.
Shehla, so can you see the pearls and the diamonds and the rubies that Breast Committee has?
Yes, Madam. Definitely.
Dr. Chaya, you have Dr. Divya, you have Dr. Shehla, we have Mangala Vani, and all of you, you know. So I'm blessed. So, you know, anything that these people decide to do is going to be a great success.
Dr. Shehla is too good. Too good.
She is outstanding. And we would really want to, you know, make a little flowchart, Shehla, so that we will circulate to all our presidents and secretaries of all our societies of India, so that we have a small, you know, like those who are keen, those who are eager, they will definitely go ahead and organize these kinds of camps. And, you know, as you rightly said, we will get more data and we will be able to make a difference. That is so very important.
The tagline was also very nice, Madam. Har ghar detection, ghar ghar detection. That was also wonderful.
So that is going to become another hashtag now for every camp.
Yes, Madam.
Is it not? So thank you once again, Shehla. I think we know there are so many questions in all our minds that we'll have to have a dinner meeting with you one-on-one to get all our doubts clarified. But it's a great way to start, and we are so happy that we took this topic in our webinar.
Thank you, ma'am, for having me here actually to express. And algorithm, reckoner, and follow, plan, advice, everything is ready with me. I'll share it with you, including questionnaire.
Absolutely, absolutely, Shehla. We'll take it forward from there. Absolutely. So, Dr. Monica, over to you.
Shehla ma'am, it was very, very nice to hear you after a long time. You truly deserve a standing ovation, ma'am. At the end of the session, I would like to conclude by giving the vote of thanks officially to all the office bearers of FOXY who could join and who have joined and who have not joined also. That is Dr.
I just want to, can I interrupt? Dr. Alka Pandey madam just called and I think she's watching us live on some link. So that was a good thing.
Yes, ma'am.
Thank you. Yeah.
I would first and foremost like to thank our chief guest, Dr. Rishikesh Pai sir, our guest, and Dr. Rajendra Singh Pardesi sir, the guest of honor, Dr. Smita Tandurkar madam and Sneha Bhuyar madam. Also, Dr. Madhuri Patel madam and Sujata Darvi madam for extending their best wishes and being so supportive to all the programs. Both the vice presidents, Dr. Yashodhara madam and Dr. Alka Pandey madam, who have given us a free hand to work without which, ma'am, it is absolutely not possible to work, because they blindly trust us so much that whatever we do, they are always there with us. We thank both of them for the same. I would also like to extend my thanks to Charulata Madam and Priyankur for giving me an opportunity to conduct this program under the banner of AMOX also. We also would like to thank all the faculties, Dr. Girija Wagh Madam, Dr. Divya Sangal Madam, and Dr. Sayala Jamal, who have put in a lot of efforts to organize and gather so much of information in such a short span of time that it is truly, truly benefiting to the delegates. Dr. Charulata Madam and Dr. Rashmi Madam, the panel discussion was the icing on the cake, as I said, ma'am. It was truly exhaustive, and all the topics were discussed extensively by all the panelists. I also would like to extend my thanks to Shamila Madam for being the expert panelist. I would like to thank all the chairpersons, the Master of Ceremony, Pratibha Madam, Divya Gora Madam, and Taruchaya Ma'am. Last but not the least, the Corona Remedies, who have given us the academic support. FOXY, Breast Committee, FOXY PAC, as well as AMOX PAC committees have put hands together to put forward this academic front in front of you. Let us all take the benefit from this. Thank you so much, everyone, for joining in.
Outstanding, outstanding, absolutely. I think Corona Remedies deserves a big round of applause. Mr. Abhishek, you have been so patient and you've been so kind as to bear with all our ups and downs. And in spite of that, you gave us.
Thank you so much, ma'am. Thank you so much, ma'am.
And this would not have been possible without your, without your untiring support throughout these last 15-20 days.
Thank you, thank you.
I think it was a pleasure having everybody here. Thank you, dear faculties. Thank you, dear delegates. And thank you, everybody, for this wonderful webinar. And I'm so happy that I did my first webinar of my tenure with my parent society, that is AMOX. Thank you, AMOX. Thank you, FOXY. Thank you, everybody, for being here. Thanks.
Congratulations, Dr. Charu.
Thank you so
Such a
much.
successful
Yes.
webinar.
Can we stop the recording and then